Day-3 Nanzarina.
Good morning, colleagues. Welcome to Day-3.
Morning, colleagues. Welcome to Day-3, the last day today.
I'd like to first begin with the Philippines Bantanam. I hope I'm correct in the pronunciation. I think it was an inspiring journey. They have the challenges, but they are overcoming, they are scaling over. They have 3 small islands from the mainland. They have to rely on the high tide to be able to go to the other place. And if you rely on nature, there can be challenges. There are times that they have storms. There are times that they are delayed, and they can be marooned at the workstations where they've gone. We saw the story of that young man who had tuberculosis, pulmonary, and the community and the family, they thought that he was bewitched. They didn't even want to take him to the hospital because they were saying he would die. He had been at the hospital. But we saw the determination by Dr. Samaya. We saw the determination by her team. They still managed to go and bring the young man. He got onto treatment. Right now, he has recovered. They showed us his happy face. He's already planning on the next chapter of his life. So those are the success stories which inspire the TB journey. They also use this portable equipment, the portable machines from Molbio. So they are bringing the hospital, the diagnosis, right to the community. It was very inspiring to hear that you don't need a facility to be treating people. Rather, a makeshift facility can be taken to the people. So let's not have the idea of a hard-to-reach area. There is no hard-to-reach area if we are determined. We saw it from Bantanam in the Philippines. So thank you again very much for that inspiring story.
We also discussed the processes of introducing INTP in countries, the benefits, and the criterion of placing ITNPs in communities. And we heard lots of success stories and challenges as well. Challenges seem to be across the board, so we won't go into all of them. But suffice to say, they're not insurmountable, as we saw from the presentations from the various countries.
From Ethiopia, which is the second populous country in Africa of 120 million people. So the health delivery for such a large population is taxing and cumbersome. But the team from Ethiopia told us that it's possible, it's manageable, and they are doing that. They are in the 30 high burden countries globally. And scaling that requires the use of modern tools, of diagnostic tools, which are portable, which can be taken to the people. And they are doing exactly that. They now use the TrueNut. I think from 2016, they have been using the Gene Expert. They are not stopping to say, we are maintaining this. When a new gadget comes, they take it over. They welcome any innovation. They welcome the AI. There's this scary thought that artificial intelligence will make us obsolete, but we have to embrace technology. We have to make use of technology. Imagine 20 years ago, we were not even using the mobile phones as much as we are doing. The mobile phones have not taken away our freedom. they've enhanced the work and the quality of the work. So let us enhance all these tools that science is bringing to us. Let us not be closed-minded. It's not business as usual as we are tackling TB. As we are trying to end TB, we are off track.
At the cost of Catherine giving another session here, I'd have to stop her and just say a shout out to Zambia, who has officially come on board with TrueNet. Big round of applause for them.
Thank you. Let's embrace molecular testing diagnosis. Let's not just remain in the microscope. We used the microscope for years, but let's also embrace technology. Thank you.
Thank you, Catherine and Zarina. And I would just like to add one more sentence there. Let's embrace the latest technology, particularly that which can be taken to the doorsteps of people who are most in need of it. I now invite Seema Ansari to share her thoughts on the intersection of corporate social responsibility, philanthropy, and healthcare. Seema specializes in fundraising, strategic partnerships, and corporate engagement. Over to you, Seema.
Good morning, everyone. Thank you, Subit, and thank you, Dr. Srideva, for preponing my session. Thank you. So we'll talk about corporate social responsibility. There were a lot of questions, a lot of queries that we had heard from people. This is a very generic, I would say, presentation that I would like to make here. Reference to India and a little emphasis on what the government has talked about, a TB-free India. What we say is Pradhan Mantri TB Mukt Bharat, which means Prime Minister's TB-free India initiative. So corporate social responsibility is basically started, I mean, it was always there, but it became an act in 2014. In 2013, implemented in 2014 in India. I would just read out some parts of it, which says Schedule 7 of the Act indicates the activities that can be undertaken as corporate social responsibility, which broadly relates to health, sanitation, education, environment, sports, heritage, art and culture, rural development, slum area development, disaster management, including relief, rehabilitation, and reconstruction activities settings. It's just a very generic, but we have a detailed understanding of each of these activities. For example, if we talk about healthcare, it includes a whole lot of activity in terms of preventive healthcare, screening, testing, diagnosis, treatment, etc. So we will focus on the subject is like supporting the national program through extra budgetary resources. What we understand from here is the government has allocated certain kind of funds for each of these sections, which I have just mentioned. But extra budgetary is how we can talk to corporates, philanthropists, HNIs, individuals through their philanthropic initiative can spend money for various activities. It could be education, it could be health, it could be even promoting sports, rural development, disaster relief, etc., so on and so forth. Next slide, please. So what is CSR? CSR is basically businesses engaging in initiatives that benefit society. I would just like to say, when you talk about CSR, means businesses which has a heart of a businessman, a mind of a businessman, but a heart of a philanthropist. That's how it works. You have to marry the two to start working for the community, to start giving back to the society where they have made business thrive. So it's in a very simple word that I would say, what is CSR? It's a legal framework, as I had mentioned. Companies Act of 2013 mandates certain companies to spend 2% of their average net profit on CSR activities. So any company which has a turnover of certain amount, the average cumulative of that particular year, they have to give as a philanthropic or CSR initiative to the activities of their choice, which has been laid out by the government of India. Of course, who doesn't know philanthropy? There are so many philanthropists around. We just have to tap them and talk to them. We keep reading about them on newspapers. I would give some example from India. Is the Azim Premji Foundation, and there is Reliance Foundation. So these are all billionaires, multi-billionaires, Warren Buffett. These are people who have also come together to promote philanthropic activities through a a corporate giving, through their own foundation, or for that matter, even like for example, I'll give you, there is a very big pharma company, and the founder of that company, every year, whatever investments he makes in his stock, I mean the equity, the dividend is then given out as his personal contribution towards one of the philanthropic cause. So those are various ways, where the founders of company, the CEOs of company have started giving back to the society, because that's a surplus which they have with them. I don't know whether you can read the, can you move the chair, please? So what happens when someone starts giving back to the society? There's a level of trust that you start building with the community. For example, I would give you, these are purely examples from India. There is this private sector unit, a PSU, which heavily invests in, say, for example, electricity. And they wanted to reach out to the community and how to break the ice. So the best thing that they could do is to start working on a particular cause. For example, TB, testing and screening of tuberculosis in areas where they wanted to promote post-paid electricity bills, because there was a lot of theft that was going on. So they wanted to build the trust that the company is doing good for the community and in the right way, and then promote their own business agenda, which is of course not going to take away a lot of money from them, but of course stopping them from taking away the electricity without paying any bill. So through these activities, the founders of company, the PSUs, public sector units, are trying to get into the community, doing good for them, building a level of trust. It's only going to help them and create a very positive impact on their health, on education, on various other things. So uplift them. That's the whole idea, to uplift the community in the right way and in the positive way. So next slide. There's a definition by the World Economic Forum. They have defined CSR as a contribution that the company made to society at large from its philanthropic programs, business activities, and engagements in public policy. The contribution that a company makes is determined by how it manages its social, environmental, and economic impact, and how it manages the relationship with the different shareholders, which are their consumers, their employees, partners, government. I'm talking about everyone. CSR affects everyone. Every stakeholders are impacted. Even their employees, their families, all are impacted under CSR. So you have to take everyone all together and work towards a common goal. So next slide. Okay, this is my favorite slide. I keep using this every time in all my presentation. What happened after the pandemic? We all know how the world was moving, but what happened after the pandemic is a very clear transformation that happened. Everyone started using all the digital platforms because there was no personal contact, there was no physical contact. You'll see a lot of UPIs coming into play, digital platforms. Work from home was what it was, and we had Zoom, we had Teams, even everything went digital. So that was one big positive impact I could see that happened. It was a game changer. Today, when we talk about even diagnostic tool, is a game changer. Today, the PCR can reach to the farthest of the place. That's a game changer for everyone. Revenue focused. People started talking about how we can, make money, we can save money for the rainy day. And I would say what impacted and greatly everyone working towards community. It's community centric, doing good for the community. Pandemics, we saw everything that could happen. And the worst which was impacted were the community, the NGOs, who are really working very hard to make ends meet. And people all came together and made the community and the NGO as a center point. And it's applicable even today. What we learned from it is to innovate. Very important. If you don't innovate, we die. So you keep innovating. You have to adapt. You have to sustain and grow. The last is collaborate. Nothing can work without collaboration, which is government. You have your corporate, you have your employees, you have your families. Everyone has to collaborate and work together. Not one or two. Like if I say I want to work in silo, if I'm just one organization who wants to work towards eliminating TB, I can't do that. I need all hands on. I need people from all walks of life to walk with me and say, yes, we can eliminate or end TB. And there is a goal that is there in our mind, and we all have to work towards it. Next slide, sir. So corporate giving, I'll just break this into 4 or 5 purpose, I would say, stages. We all know earlier how corporate giving, or I would say giving was. It was through families, through friends, or it was very focused that this is my favorite charity and I would love to give it to it. Just cut a check and give it out. That was the early stage of giving. The second was program and projects. I want to invest into a program, I want to invest into a project, and then just find out how it works. Again, not very, I would say, it was not very systematic or organized. Then came the third phase, which was activities. People were only focusing on one particular activity, that I would like to fund for a particular activity, and that's my giving. But I would say that what we are currently doing is the 4th and the 5th phase, which is impact and purpose driven. What if I invest $100, what impact I'm going to make? And what is the purpose behind it? It is all about purpose driven. So I think community is all about how we are going to impact the community, what is the purpose that we are there, and how we can make the most of it, even from that $100 that we want to give out as an investment. I will never say donation or charity. It's an investment that the corporate makes and gets a social return on their social investment. Yeah, next slide. A lot of people, they have asked me, how can we actually go about and get funds from corporate? There are various ways. So one is, of course, the government grant. The government has started some initiative, and there is an investment made by the government, which we can directly apply, or there is a proposal that we can make and go out to the government and look for it. RFPs are being floated. We can always keep a check on that. The other is corporate CSR funds. As I said, in India, there is 2% of corporate funds which are allocated by each company, which is making a certain number of profit every year. So we can tap those. Every corporate in India has a certain who falls into the CSR list of companies, have a certain area where they would like to invest. Education, and health are the largest, I would say, in India, where people are focusing on. Especially after the pandemic, health has become a priority for everyone. That one area where you can give. Employee giving. For example, there are about 200, 300 employees in my organization, and I would write to everyone that there is a particular cause we want to fund for. Every employee would say, okay, and this is not compulsory, it's like, maybe very voluntary, that they would say, okay, I would like to donate a part of my salary that month for that month towards a particular cause. You can have that pool of money by the end of the month and give it out to the community or to the cause that they would want to promote. There are foundations, like as I said, there are large philanthropists who have opened their own foundation, which you can give grants to. You can always tap them, talk to them, find out who are these people, and look out for grants which are available in your state or in your community or in your country. Volunteering, that's one big area where people have not yet tapped. It could be youth driven, it could be company driven. Volunteering is a very big area where you can mobilize the youth to talk about your cause, to create awareness, and to always raise funds. Cause marketing, we have always seen that how cause marketing plays a very important role. Maybe you all can say that my product, just giving an example of P&G, Procter & Gamble, they came out with a very big campaign that every time you buy a product, a percentage would go towards the cause. So I think these are the companies who are very open, and these are from the marketing budget which comes. So it's not only the CSR, you can also tap into the marketing budget of companies. Of course, as I said, philanthropists, you can always talk to philanthropists if you can get a meeting with them or an appointment with them, talk to them. They are very open to listen to you. And of course, if they believe and if it is purpose driven, they will definitely invest. Of course, the other one is USAID, the global fund, which we all know, we have been talking about. Media-driven campaign. A lot of time media, we have to sensitize the media. And if they are open, they come out with very good campaigns. It could be a radio-driven, it could be a televised campaign. We have seen NDTV doing a lot of campaign around, even on World TB Day. It need not be just fundraising, but general awareness. So in your countries, you can always go to media, radio. People listen to radio all the time. So talk to them, and if they can come out with a very good piece on awareness, for example, TB. So there is a messaging which can go all out on television, on your print, and of course on radio. So do tap and talk to them. If there is an opportunity, you can always tap into that. Aggregators, we all know that there is Give Foundation, Friends of America, there is United Way. They have various other platforms where you can reach out to them and start a campaign with them. Of course, there is a percentage which they take from the entire funds that they have raised, which is the admin cost. But overall, there is a whole lot of awareness also that is created about a certain activity that we want to do. Digital campaign, awareness, fundraising on days like World TB Day, World Cancer Day. We have seen a lot of activities around World TB Day. So you can reach out to, media, you can reach out to corporate and say, hey, there is World TB Day approaching. Of course, you have to plan at least 6 months before World TB Day or World Cancer Day and say, can we do something together? Because if you are there, if you are seen and you are heard, people start giving out fundings to you. There is a trust which is being built up, but you need to be there. People should know you. That's very important. And through these activities, through media, through aggregators, through digital campaigns, we can always be seen and heard. Next slide. There are some numbers which I have taken, like how the government has allocated funds towards healthcare. This is very India-centric. So there is an overall increase on healthcare and in the national budget. Significant portion has been allocated to the National Health Mission. There are some numbers from 2023 on the recent allocation of budget, which is USD 10,344 million for health and wellness. So you can see the number which has gone up for Ayushman Bharat, which is a national public health insurance scheme by the government of India. that aims to provide free access to health insurance coverage for low income earners in the country. I'm sure, if each of us can start talking to our government and push them for such initiative, it really will help. At least start talking. These are some good examples from India, which we can start picking it up from here and give them some ideas. I'm sure maybe some of them may not know, but if you can start pushing insurance, healthcare initiative, I think they'll start hearing you. Maybe not immediately they can act upon it, but at least you can leave them with a thought and of course follow it up. I'm sorry, so the key initiative is provide healthcare up to 5 lakh per year per family. These are something which I will leave my email ID with you all, and we can talk about it in detail, how each of these programs have worked in India. Yeah. So next slide. There's a government allocation of funds towards tuberculosis. TB in India. India accounts for 26% of the global TB cases. Sir, Dr. Sadeva, if maybe you can elaborate more on this as I talk about the budget allocations, picking it up from the sources. Sure. Sir. So these are the increased funding in the national program for TB in India. Numbers have been taken from the sources of the government website. And look at the budget, which is like, there is a good investment which the government is already making in India, has been making. So the goal is to end TB by 2025. Of course, we have done a lot of work towards it, and if we may continue to work towards elimination. The goal may push to 2030, we don't know. But of course, everybody in India now knows that we have to end TB by 2025, because there's a whole lot of push which has come from the government, from the corporate sector, even individuals, from healthcare workers. So all of us, we are completely in sync with the government initiative. And it could only happen because a lot of awareness, a lot of understanding, sensitization, which has gone through with efforts from the government, with efforts from NGOs, with community, and from corporates. So you must have heard about Nikshay Poshan. A lot of people were talking about nutrition. Government has also initiated the Nikshay Poshan. So you have to adopt the TB patient for their nutrition. So corporates are very, very keen to have money allocated for the nutrition of the TB patient, which is a substantial amount. It could be more than, sorry, what is the amount which you say? 1,000 rupees per person. 500 rupees per person per month. And corporate can pick up about 6 patient, 10 patient, even 100, depending upon how much they can allocate towards it. And government gives them a complete subsidy on the tax as well. So there's an exemption which they receive once they start giving out to these causes. Next slide. There's a CSR allocation of funds by the corporates. The total expenditure by corporate in 2023 is USD 2160 million. That's a huge, huge amount which is sitting. And I'm sure for 2024, there will be another few millions which will be added to the entire kitty of, this is only corporate giving. This is the surplus which the country will have. This was last year, but in 2024, we'll have much more. So 30% of CSR funds is directly towards healthcare and sanitation. So you can understand the amount which is there for the corporate to spend or to invest in healthcare. And as I said, the major sectors are education, healthcare, rural development, and environment. Everyone is talking about environment, and we can definitely link this up with healthcare. Anything to do with environment, I think there is a direct relationship to our health. Prominent initiative, the Tata groups, they have invested heavily in almost every field. They are there in education, in healthcare, in rural development. You talk about sanitation, you talk about even sports. So Tata has been one major player and the other one is Reliance Foundation. But there are many more. I mean, there is a whole lot of, there's a whole list that I can send off to you. What I wanted to say, I'm sure these organizations, these companies definitely have their offices in your countries. You know, if they are investing in India for CSR, we can always reach out to them. If they can also, because they're already having their work, their offices, their plant in your countries. It will be good to at least start talking to them of giving back to the society wherever they're operating from. So if they can invest here in India, I'm sure they can look at other countries too. So next slide. So these are the numbers again, which is 26% of the companies have healthcare and WASH as their first CSR priority, followed by environment and sustainability with 23% and a promotion of education with 23%. As I said, environment sustainability has emerged as the second largest and third largest CSR priority area. It works very well for us too, people who are in the healthcare sector, because when you talk about air pollution, it directly affects your lung. And we can always correlate and create develop a proposal and talk to companies who are investing in environment. Yeah, next slide. Sir. These are some numbers. The percentages where and how the allocation of CSR funds were done in 2023. The last one is coming up, which is employee giving. I think that's one big area where we can start talking about to companies. If you have a friend working in an organization which has a strength of 2,000, 3,000, or 1,000 people, your friend can always talk to the higher ups and see if there is a funding opportunity which we can see. I'll give you an example. I would say, when there is a World TB Day, we can actually start talking to the employees or even to the media. As I was talking about the digital, campaign, where we can say, okay, we need consumables for a TB free. There is a community which really needs your attention. And we can start a campaign that your investment or your donation of say $1 will help us create a positive impact to one of the TB patient. So you can talk about those numbers. Say if there are 500 TB patients, you can run a campaign on World TB Day that every investment made by an individual will be going towards treatment or towards screening or diagnosis of a TB patient or a community in that particular district or an area. We can start talking about these things. That's where we can raise our investment in consumables, and we can say, okay, yeah, there is the equity, there is an amount which we can buy more products. Next. This is 2022 numbers, where we were in 2022, and there is an increase of 20%. We are yet to receive the numbers for 2024. Again, every trend shows a shift towards healthcare post-COVID. Next slide, sir. This is TB Mukt Bharat, which is a TB-free India initiative by the Prime Minister of India. And of course, the government was launched by the government of India to eliminate TB by 2025. The objective was early diagnosis, complete treatment and prevention of TB, strengthening health systems and patient support. Again, the strategy was very simple: community engagement and awareness campaign. Of course, not very simple to get into the community, but yes, we were successful in doing so. So you can see the progress, reduction in TB incident by 12% since 2018. And there is an increased treatment success rate to 85%. Of course, Dr. Sadeva, Shwini Khanna sir, and Mr. Chopra can talk about it if there is any questions from you all. Next slide. I was talking about volunteering and corporate TB pledge. This is volunteering, of course, is picking up. I would give you an example of Johnson and Johnson. They have come up with a very, very smart campaign called Be the Change for TB, where they have been successfully mobilizing youth to create awareness, to do volunteering work, and also, of course, raise awareness and raise funds towards TB. So we can mobilize the youth community in a big way. And the market is huge. It's 1.5 trillion annually. So UN has a separate wing on for volunteers. We can definitely tap them in from each country and talk to the UN of the country and say how we can mobilize the youth community. As I said, if you are there, if you can create awareness, people know you, it's very easy to mobilize funds. Corporate TB Pledge, this is one initiative which was funded by USAID. And this was, I'm sure a lot of people have been talking about it, where the corporate, not only the corporate, I would say even the celebrities and media have started taking a pledge to eliminate TB. And it's just not the pledge, it's also doing work towards elimination of TB in whichever capacity they can or they could. It could be adopting a patient for nutrition support, it could be screening, it could be testing. So we can always reach out to corporate and say, how can you multiply this effect? Can you take a pledge and help us eliminate tuberculosis from our country? And this could be a campaign on its own. This could be an awareness campaign. It could be, whatever we can, advocacy. We can call people for a summit, for a conference, for a one-day seminar, whatever. I mean, it's up to you how you can reach out to the corporate and make them take a pledge, and call media. I think when media is there, you can sensitize them and they can talk about it. When we are all over in the newspaper, in print, in digital, radio. So I think that's a very good tool which was started by USA to tell the corporates and ask the corporate to start taking pledge. Yeah, next slide. That's some part of it, which is how we can reach out to USAID, Global Fund, and where they are investing. One thing which I would like to talk over here about the Gates Foundation, which has invested with an international organization on ACSM, which is Advocacy, Communication, and Social Mobilization. It's a very big piece where they have been talking about TB elimination and developed a lot of content, lot of material for everybody. I mean, it for the audiences, it for general public, it for private practitioners, it for ASHA workers. So everyone has a literature which they can fall back or look at. And even a video which can go all out. I will play the video after the session, after my presentation. It is in Hindi, but it talks about how people have from all walks of life have come together and they have said, yes, we want to eliminate tuberculosis from our country. Next one, please. These are some understanding about corporate support for TB causes, funding, donation and grants to TB-focused NGOs and programs, awareness campaign, as I've been talking about, public education on TB, healthcare infrastructure, building and upgrading TB clinics and laboratories. These are some ways where you can, prepare or develop your proposal. How we can tap, what is the starting point? What is the messaging that you want to give out to your corporate? And you can definitely develop and build on to these pointers. Innovative initiative or TB research and new drug development, mobile clinics, providing TB care in remote areas. Definitely it works really well because it's a one-stop shop for everyone. The corporate is very happy. There's a good branding of the corporate on the mobile van, which can go across. I will give you an example of SBI, which is the State Bank of India. They love to have their branding on these mobile vans because it reaches out to the far-fetched. Of course, it also serves the business purposes to open their, to increase their number of accounts or I would say investors. So these kind of branding also helps, in which plays a double role where they invest in a mobile van, they have the branding across and it reaches out to a whole lot of audiences. Opportunities are enhanced public-private partnership for TB eradication and increase investment in TB research and innovation. Next slide. These are some benefits of CSR, which you can incorporate in your presentation, how it will benefit the corporate. It's about you win your business. If you are seen, it's about goodwill. So if you look good in the eye of the community of people, you definitely increase your businesses. Like Unilever, when they come out with their, or a P&G, when they have a cause marketing campaign, people buy more products. What happens? There is an increase in their sale, but they're also doing good. They're investing in a cause. So they look good in the eye of the people, and there is a trust which is being built. Enhanced relationship with stakeholders, of course, and attracting and maintaining a happy workforce. So people are very happy. They're saying, okay, our management is doing some good work. We are also investing in some good work. So when we talk about employee giving, people feel good about it because it's just not work. They're also investing their time and their money in a cause. The media interest and positive reputation, access to funding opportunity, enhancing your influence in the society or in the industry, differentiating yourself from the competitors, very important. Saving money on energy and operation cost, increase in customer retention. Who doesn't want to go back to your to a company which is doing good? So there is a recall value over there. Next slide. So I would like to end the session by saying, be the change for TB and stand together in reaching the common goal for a TB-free India. This is India, but I'm talking about a TB-free world here. So learn about tuberculosis, spread the message, grow as a youth TB change maker. So very clear message over here that we all have to come together and work towards a common cause. There's a small video that I would like to play. Hindi. Yeah, yeah. We'll quickly finish this. Yeah.
हौसला नया भर लिया है, फैसला ये कर लिया है, टीबी से सबको बचाएंगे, खुद से ये वादा कर लिया है। इंडिया जब जोर लगाएगा, टीबी हारेगा, देश जीतेगा। इंडिया जब जोर लगाएगा, टीबी हारेगा, देश जीतेगा। टीबी से मिलकर लड़ना है, चौकन्ना हर पल रहना है।
खांसी बुखार वजन हो कम तो जांच कराने चलेंगे हम।
इंडिया जब साथ आएगा, टीबी हारेगा, देश जीतेगा।
टीबी मुक्त भारत का सपना है, ये सपना सबका अपना है।
आसान है इलाज इसका, बस भरोसा मन में रखना है। इरादा अपना रंग लाएगा, टीबी हारेगा, देश जीतेगा।
तो आइए आज ही सब लेते हैं एक संकल्प, भारत को टीबी मुक्त बनाने का। तभी तो टीबी हारेगा, देश जीतेगा।
टीबी हारेगा, देश जीतेगा।
So that's it. So yeah, the video just says the message is the TB will lose and India will win. So TB harega, desh jeetega. So I think that should be the clarion call in our countries and the world, that TB will lose and the world will win against TB. Right. Any question answer, we'll take it after lunch, during lunch hours. Yeah. And I will leave my email along with this presentation with all of you. You can always connect with me over email as well. Thank you.
Thank you, Seema. And we will now have a panel discussion, which will be chaired by Dr. Sachdeva. He's just coming in 2 minutes' time. And meanwhile, I would invite the panelists to please take their places on the stage. Professor Moses Joloba from Uganda. Dr. Mohammad Mahfuzur Rahman Sarkar from Bangladesh. Dr. Yevusul Sevkasi from Ethiopia. Tarit Chakravarti, TB People India. Tariro Kodatsa, Zimbabwe. TB People Zimbabwe, basically. Dr. Lalaine Mortera, Philippines. Sumit Mitra from India. So we'll just wait for Dr. Sachdeva to come and take stage. If there are going to be presentations,
That's the best way to. So good, sorry, I needed a small bio break. So I said, before you bind me for next 3 hours, let me be free from. Thank you for your understanding. So we had the 3 sort of group works yesterday, where we learned about activities and policies to reach sustainable development goals. We agreed on certain things. We discussed on certain things. So we'll build on from there. So we'll start the panel discussion with few questions. And I learned that you want to leave early. What time is your flight? 3 p.m. Huh? Okay. That's a long time. No issues. Okay. And you are from an organization called TB People India. So most of you know, and it's a community-based organization, and you have branches in many parts of the world. I met one of your, I think, founder in Philippines. We have somebody from TB People Zimbabwe. Maybe you have so in more countries. So the question to you is obviously the community perspective, and let's confine to sustainable development goals and the timeline to reach sustainable development goals. So we are not talking of India's commitment to 2025. We are talking about world's commitment to eliminate TB by 2030. Okay, so keeping that in mind, what role do you think communities can play proactively to work with the national programs, maybe also with the civil society partners, and if you think tangentially also with donors, making donors to contribute funding, civil society to take up activities, national program to get more resources, advocacy, etc. How do you see this playing out? And do you think we can reach there?
Okay. Thank you, sir, for giving me the chance for the first question. Actually, the thing is, community plays a big role. Without community, nothing can be done of what we believe, because we are facing problem. We know our problems. We know we can raise our problem, and at in front of the good people, in front of the right people, if we raise our voice, scenario can be changed. And you people are here who are supporting us, and you will be capacitate us how to say something, how to advocate. I mean, we know our issue. We will raise our issue. That's the way we can change our scenario. I think this is the thing, and the most of the thing that we are also playing a good role for as peer, because we have good reach at the grassroots level, TB survivor. So they are very much comfortable to us to say their problems. So we will be playing as a bridge between community and donor, or maybe with the government. So here we believe our role is very much important. Yeah, that's it.
Okay. So you talked about raising voice and acting as a bridge. Let me come and speak to one of the program managers. So maybe I'll reach out to Dr. Muhammad Mahfuzur Rahman from Bangladesh. So, Dr. Rahman, how do you feel when community raises voice?
Yes, thank you, sir.
What is your comfort level when they raise voice? Because they can raise voice in a way which you like it. They can also raise voice in a way you don't like it.
Yeah, thank you so
There
much.
is just give me a minute, sir. So there are
You know, their community involvement is very important to control the tuberculosis program. So in our country, community involvement is in this, and strengthen the community involvement. You know, our community clinic is the role model of the world. So we started from the community level, the program, and we awareness developing for the community people, community health worker and others community participation. So our program is started from the community level, then subdivision level and division level and upward. So without community involvement, the tuberculosis control program is not possible. So thank you so much, sir.
Yeah, so we understand it's not possible that the last mile service delivery, which Dr. Bobby Ramakant was saying yesterday, the last mile connect with the community service delivery, or say reaching the unreached, which we saw in Philippines. Do you have the trust of the community? Community will have trust of the community. Program may not have the trust of the community. So that is one aspect of it. Yes, we cannot do without them. But how do you feel when they say there are drug shortages? You are not supplying drugs. You are not supplying critical equipment. There are no diagnostic equipment, and you are not doing justice. So how do you react to them, and do you actually take corrective actions? Does it change your policy, etc.? Just would like to hear from you. To you, Dr.
Yeah, sir, again, please you say
No, my question was community can also raise uncomfortable questions,
this.
which is saying you always keep asking us to do some work, but when the patient goes to a center, there is no diagnostic available. You are short
Yes,
of
our,
cartridges.
our diagnostic, molecular diagnostic facilities started from the community level. At present, 622 gene expert machine and 150 200 machines are functioning in our community level, just Union Subcenter, Upajala Health Complex, and as well as the district hospital and medical college hospital. So our worker collected the sample and sent the a gene expert or to not site, and firstly they touch the nearest center of the facilities. So if they need to refer the district hospital, medical college hospital, and regional laboratory as well as the national laboratory.
Sure. Thank you. Some put a similar question maybe to any other program manager here. Professor Joloba is here from Uganda.
Yes.
First, your thoughts on how to reach SDGs, what we can do, and then I'll come back to the same questions on shortages. And how do programs react to it? And what he did not clear is sometimes, like in India, say we have 7,000 molecular diagnostics, TrueNat, Gene Expert, all combined. And those 7,000 molecular diagnostics can do, say, 10 million tests. But we do 20 million tests everywhere. So that way, 7,000 is not sufficient. Similarly, in most countries, when they say you can do centrally. But there is another question of SS. We saw many presentations on SS, which Philippines was a beautiful example. You may have, in Manila, you may have 50 machines, but they are not going to do tests in Cebu, in the islands of Cebu. So you need something for, as a quantitative number, you also need something for SS. They may not do as many tests as they are capable of doing, but still you need them in the periphery. So these are the two questions to you. Yeah, please.
This is ready to go. Thank you very much. I'm not the program manager, though, but I am with the program and I head the National TB Reference Laboratory and the SRL. So your question is really very pertinent, and the question of access. And sometimes we do have a mix of access and utilization. Or the NTB strategy is very clear. We have to be patient-centered. and not facility centered. Because if you begin arguing that the equipment is here, it's not utilized, are you focusing on the patient? Because yesterday it was very clear that delayed diagnosis affects all the three key indicators. If you delay diagnosis, your transmission continues, incidence will not go down. If you delay diagnosis, case fatality will go up. If you delay diagnosis, catastrophic cost will go up. So we really need to put the whatever instrument close to the population and focus on the patient, focus on the community, and not give them a lip service that you come, I take your sample, it will, the results will come back tomorrow. That's not access, that's not accurate, rapid diagnostic. Anyway, you started me on my topic, let me hand it here, otherwise we can go the whole day. Thank you very much.
Thank you. So, Dr. Lelen, coming to catastrophic costs. So I feel there are a lot of catastrophic costs, especially in Philippines, to patients. They don't have ready access. Sometimes drugs are not available. They go to private sector, pay huge prices. Diagnostics are not available. How do you think we should be addressing this issue?
Thank you for that beautiful question. When we talk about catastrophic cost, we really look at how patients behave first, where they prefer to go. Most patients would not really go to the public sector for many reasons. And they may have insurance benefits that cannot be availed of in government facilities. So when we come up with some solutions on how to at least reduce or remove that catastrophic cost, we have to first, one, respect the patient's choice and make that choice affordable, or we have to make that choice friendly. So you cannot impose on a patient, go to the public sector because it's free, but the queue is so long, and I would miss 2 days of my work, I would lose more days of income. So it doesn't, free doesn't necessarily mean the only solution. So that's when we come up with, I'm part of a project and I'm the private sector advisor, where we empower the private sector to be part of the network, not necessarily giving services for free, but at a very affordable cost. At the end of the day, if I were to, let's say, go to the health center, but it would mean several trips, that would mean more transport costs to me, more loss of income because of more days waiting for a result, but the cost is free. So when we talk about catastrophic costs, it's really looking at the patient at the end of the day and how you would make that experience affordable and less painful. So in the Philippines, we actually came up with a private sector, Philippine Private Sector Diagnostics Consortium, where we allow globally recommended tests to be more affordable in the private sector, because we would like to respect the choice, but make the choice affordable. At the end of the day, it is free, but somebody is paying for it. So it's free for the patient getting services from the government, but it's not really free because government is paying for it or Global Fund is paying for it. If I were to seek care in the private sector, I might be paying some money, but I can also avail of some benefits from my insurance. So if we are to tailor fit some approaches and make that cost more affordable, then we have to look at where patients go. But if you look at catastrophic costs, it really redounds to universal health care. So if you look at universal health care, primarily it's the primary care level that you have to strengthen. So you do not allow patients to have worsening of symptoms, will have sequela that is more expensive, and will avail of tertiary care. So we have to strengthen the primary care level. And TB care is not a tertiary level, supposedly a tertiary level care of service or a secondary level of care. It should start really with the primary care level where promotion, health promotion, prevention is key. The only problem is the health-seeking behavior is delayed. So we also have to address that. So at the end of the day, what is catastrophic cost? You can reduce that by intervening at all access points so that one, you reduce the turnaround time, you reduce the cost of service, and you make that experience friendlier to the patients. And I think at the end of the day, that would be a more impactful way of addressing things.
Yeah, that's a good model. I mean, many other countries have that kind of model where services in the private sector for patients of TB are actually free for patients.
Yeah.
And as you say, somebody else is paying. But I don't see that happening much in the many of the countries which are present here. So how do you think, my question is to now Dr. Cassie from Ethiopia, how do you think these models can be replicated across Africa? Many African countries actually struggle with private sector and finding a right donor who pays the private sector for serving patients in the community of TB and makes it free for TB patients. Do you think such models can be tried out in the African space? And are there some countries who are doing that?
So the toughest question comes to me. So I'm from UCID, and
Okay.
UCID is,
You are the right person.
it's the
To-
biggest bilateral donor for tuberculosis program.
Yeah, yeah.
So, and I think engaging, I see it in a very bigger way. Engaging everyone to the best is one of the very many things that we can take us to in the TB. So from the many things that we should engage, I mean, from the media, private sector, the community, TB patients, and other sectors, including a political segment, I talk about the private sector. If you go to, at least to the Eastern Africa, which I know very well, if a prime minister or a health minister is sick, do you know where he's going? He will go to the private sector.
Okay.
If you ask him to sign a donation of a microscope is the oldest rudimentary diagnostic technology to the private sector, he'll say no, for a reason that's not convincing anyone. So I think the first thing that we should do is to change the attitude and the thought of the political leadership, the health leadership, to open up a space, a political space, financial access, land access to the private sector. That will enable even the private sector to play its corporate role as well. And we can also continue leveraging our resources to pay the losses of the private sector. I think we should start from the bigger political segment to have the space, the political environment that allow the private sector to play its role to the fullest in terms of ending tuberculosis. If you take the case of Ethiopia, we do have 10,000 private health facilities, only the health facilities. I'm talking about the health facilities, not the other part of the private sector. We only engage 0.1% of the private health facilities in TB treatment and care. We do have a very stringent criteria to engage. But they must have a space, a dedicated personnel, a political commitment, and they have to sign a memorandum of understanding with the government just to treat a TB patient. But through time, I mean, we have been advocating for it through time, so continued advocacy, we were able to at least provide the supplies for free, like the drugs, the reagents, the cartridges, whenever there is. We were able to leverage the government systems to provide free drugs, supplies, and also build the capacity of the private sector. This is a very beginning, a very beginning, a small thing. What is required is the commitment of the government to have a political space, to have access for finance, and also to pay for their losses for providing TV service. These are profit-making institutions. We do expect them to treat TV patients for free, but these are, business-making institutions. So the first one is a policy frame that have a space, a political space for the private sector to be engaged in TV. The other one is we need to also engage the other part of the private sector to play their corporate role, continue financing the private sector, at the same time also scale up the initiatives in India where private philanthropists, individuals are also playing a role in terms of supporting patients. So having the right policy framework within the host government can also help other actors, including Global Fund, ESCID, whether DFID, all of the donor community to take part in the private sector, including paying their losses, compensating their expenses. Thank you.
Yeah, good thoughts, but I think the purpose of these kinds of meeting is also cross-learning. You should learn from some of the Southeast Asian countries. Bangladesh has a huge private sector involvement. Myanmar also works very well with professional association, private sector. India has done very well with private sector involvement. And believe me, this did not happen overnight on an hour day. It was a long process. What we started in 2012, engaging with private sector and engaging with political leadership, getting their buy-ins. 2012 private sector notification to TV program was 3,000, only 3,000. 2023, 11 years after, we started pushing, and donors have a big role. USAID, Gates Foundation, Global Fund, World Bank, whatever donors you have in your countries, to start pushing. I mean, you have to engage with them. In 2023, 800,000 notifications from the private sector. So 11 years from 3,000 to 800,000. That's the potential. Many of your countries even don't report, have a total estimated burden of 800,000. That's the potential which is possible outside of the national program. That kind of funding becomes available if you start working with them. Nothing will happen overnight. If you have a 5 years or 10 years time frame and start working now, start benchmarking, I think countries in Africa can also aim to replicate that success, and many Southeast Asian countries can actually show you the way. I mean, it's a different model in each country. Bangladesh has a different model, Myanmar has a different model, India has a different model. But that model is there to replicate. Amar Shah, the USAID division chief for TB in India, who was here yesterday. So they fund one NGO in India to engage with corporate sector, bring them into TB fold. Believe me, 400 corporates are into TB fold in just five years. 5 years. 5 years is not a long period. Soon you will see 2030. You'll start getting people from the for-profit sector contributing to your missions and goals. I think one has to make a beginning somewhere. And if there is some help needed, I mean, we are all, you can have cross-country, you can ask for actually support from other countries.
Yeah, I mean, there are very convincing, bold results from our own side. So
Yeah.
if we did our own math, so by investing like close to 30 to find a TB case in a public sector, you need to invest close to $65. To find a TB case in a private health sector for us with USAID investment, it took us between $25 and $30. So that was really a big leverage for us to start pushing. And a year before last year, we started to place WRDs to the private sector. And we started to expand the engagement of the private sector. So it's a huge difference, like a twofold difference between the investing in a public and a private sector.
Yeah. I'll give you my country example also. I'll talk in rupees, but numbers are numbers, you will understand. Public sector pays 4,000 rupees for each patient diagnosed and treated into TB fold. Private sector does that the same in 2,500 rupees. They are more efficient. It also actually saves your money. I'll not put you on much of a spot. Coming back to Sumit. So Sumit, India has, I'm using an example of India because we have microscopy centers. They are 25,000 in number. And when you're thinking of replacing smear microscopy with molecular tests, TrueNat or any other molecular test, we did one study few years back and we found 50% of microscopy centers do just 1 or 2 microscopy a day. Ideally, it's less than 2, which is just one slide examination per day. So when I was raising the question of SS, so on SS basis, you'll never be able to put up your molecular diagnostic there because they'll say it'll just do 1 test a day. What is the use of putting it there? So you are using it instead. If your UNO can do 10 tests a day, you are utilizing it at 10% capacity. How do you sort of see this and how do you convince programs to go for an SS? What is the sort of your compelling argument based on how should program take it?
First of all, thank you, Dr. Saab, for the question. And at the outset, very privileged to sit among this august panel. Yeah, taking the India experience, of which now we have nearly 10 years of experience, more than 5 to 6 years in the public health. Molbio, right at the outset, was thoughtful and therefore made 3 configurations of the systems that it provides. And all, of course, doing exactly the same work, but each catering to a different kind of workload. With experience, we found that across the country, and you're right, that the average number of tests per public health unit site varies between at the and say 1 to 2, and with the to get all these machines connected, and then seeing day-to-day exactly what each individual machine is. I can give a specific example of the state of Andhra Pradesh, which actually was a big start to Molbio's overall efforts. It was earlier a very big state, but it's now been cut into 2. So the state itself now has around 700 devices. So over a period of time, we were able to figure out that the TB cases or incidences were not homogeneous across the state. So having connected all those 700 devices to a central dashboard, we were able to figure out areas of high burden within the state and areas of very, very low burden. And therefore, the state government machinery were able to kind of efficiently redeploy systems, taking it out from those sites which really had very insignificant number of cases and deploying them to the high burden sites. So this is one of the ways that we have been able to convince people. But again, over a period of time, as you gather more experience and now we have enough data, we can, rather than put it as an argument, we go as kind of a consultant to the government, telling them, look, if these are the scenarios that you're expecting, then probably this model will work best. rather than either underspend or overspend, because the three configurations have three different price tags. That is one way. I would just, if you allow me, sir, to touch upon what Dr. Mortera said between the public and the private. So as a conscious diagnostics company, and this has been the outcome of a lot of deliberations between Molbio and USAID and at various international forum. I remember at the EXA conference, there was a lot of genuineness in a ask from the funders that companies like us do not have a differential pricing between public health and private health. So Molbio immediately made a conscious decision that our pricing too between public and private would not be very different, if different at all. So we've been able to allow them that flexibility. The only ask from our end was that, as he says, the private enterprises are always making profit. But if those profit, and in India, the government has been conscious by keeping a cap. There has been a cap beyond which the private laboratories cannot charge a TB patient. So if that can be, taken forward by the other countries, I think that will create a huge, huge difference. But by and large, I think that is the response, my response to your query.
No, so generally, I mean, even if you look at global fund proposals, etc., now they are not giving equipment to a particular disease. So they have another component. So it'll be TB, HIV, malaria, and resilient systems for health. So equipment goes there. So the point which you probably did not bring out, and which now Global Fund and many other donors are saying, is that these equipments are disease agnostic. It's not a TrueNat TB. It is not a TrueNat HIV, TrueNat malaria. So where I can test only one patient for TB, but I can test many for dengue, malaria, chikungunya, HIV, Hep B, Hep C. So one argument lies there that as you go to the periphery, you use them for multiple diseases. You use it, devote it to the system rather than to the a disease specific area. And secondly, the same system actually can also be carried now to a field like they did. You're not using it 6 days a week. If there is just 1 or 2 patients coming, you are not using 6 days a week, 4 or 5 days a week. It can actually go and screen out in the community, do that. So it serves another purpose, which is active screening. Instead of waiting for patients to come to your center, you can use the same equipment for screening for diseases. Take it to the field, and that's how you build the confidence of the community and sort of also increase case detection. Also detect multiple diseases like the Meghalaya example we showed. Now you have something which is lying idle. So why not devote it to the community there? It's also for the programs, they can do that. And in the end, if you work the public health pricing in terms of cases detected who wouldn't have been detected if you have not moved,
Correct.
then the money is not a criteria there. For that case detected, it's a question of life and death. So if it's a question of life and death, I don't think anybody considers money there. I saw the one boy who was lying on the bed. Do you think that family will care for money? They will care for somebody comes and takes care of it. So there are different ways to look at things. And that's how we started looking at expanding. We started looking at things. When we placed many of such molecular tests, in fact, TrueNat in community health centers, which is 10-bedded hospital, which is at a population of 100,000. So each 100,000 population will have an equipment, will be used for all diseases. So that, and then if you try to model it out, it will turn out to be much cheaper. You have actually addressed the concerns of this. I'll come to the community member to reflect on this. So you are Teriro. So Teriro, what do you think about placing diagnostics and drugs at a very, very peripheral level. So that, and utilizing them not in the sort of facility, but going out proactively in the facility, touching base with the community and meeting their needs. Do you think it's a workable proposition, or it should not be done?
Okay, thank you so much for the question, but I think I have to introduce TB People Zimbabwe because it's a new baby. It was just launched at ICASA December last year when we were launching Africa Global Call for Finding All TB and HIV. And the aim just to amplify the voice of TB by preventing all, treating all, and people-centered rights-based. I just wanted to say, I think I should mention that. And I think today, Find TB, I think we've got more than 500 endorsements around 50 countries. And I think I've seen a lot of people endorsing from this, and it's most welcome. So I think I'll start with the role. What is the role of communities in all what we are talking about? Our role is to complement government efforts. That is very important. So when we are engaging with the government, when we want to be part of the government, it's not like we are fighting or we wanted to do accountability to the government. Our role is to complement the government's effort. So when we say government bring the diagnostics to the people, bring the medication to the people, we are seeing a lot of barriers when all these issues are at central locations, but we are living in different locations and so forth. So cater for those barriers. We are saying bring those services to the people and to cut a lot of barriers, even stigma. Stigma sometimes it's like we live in different places and so forth. So when you go to another clinic to assist and you're coming from another village, there's a lot of stigma. But if things are brought to the same community with the same values, same norms, people, we can even reduce stigma. So we are saying, and also programmers and NTB managers, you follow money in most of your programming. So when we say bring these services home, we say we see the barriers in our communities, but sometimes you follow money, you follow the donors' strategy and so forth, but you forget about us. For example, on that note of diagnosis, yesterday I was in a meeting on a diagnostic pipeline, and I was shocked. They said, meanwhile, more than 70% of young children with TB are never diagnosed. So as long as we don't have funding from USAID, that speaks to diagnosing these children. We are going to miss them forever. But as communities, we can bring that voice to say, we are missing the children. We are having children in our communities and so forth. So our role just complemental and amplifying that voice. So on that note, our donors, our NTP managers, our programming. So we are saying there is an urgent need to improve approaches to TB screening and diagnosis. Increase access to the best available TB screening and diagnostic tools, and invest in developing new tools needed to closing testing gaps. So that's our role. We just want you to close that gap. The gap on testing, that's our role as communities. This is our cry. So our role is just to make that shout, that cry. Yes, there's a gap here. Yes, there's a gap here. So it's not fighting. Government, we are not fighting you, but we want to work together. So I think that there's an eye that you have the communities that programmers don't have. There's an eye that donors don't have. Because normally donors, we are following the strategy. We are following sort of a systematic way of doing things. But where we live, we don't live in a systematic way. Things prop up. I think we learned a lot from COVID. COVID was a game changer in a good way, more than we say it brought a bad ways. It was a game changer. It makes us look differently. So the community has got that eye that is missing in our strategies to say, as long as we don't bring diagnosis to where we are, we continue miss people, especially children. I think we even our first TB UN level meeting, the talk was of missing children. Last year, the same, it's missing children. Yesterday, this diagnostic pipeline event, we are missing children. 70% is a lot. It's a lot. Like in my country, I think children and young people, they contribute 60% of our population. So if you miss 70% of that population, can we end TB? I thank you.
No, you brought a very important point that use community as your eye. I remember Sumit's word, don't see through your ear, see through the eyes of the community. They will see it. I'm remembered one of our community members.
So I can say that we are not the problem, actually we are the solution. So we can give you the path, we can show you the path that this is the right thing. It may be not so much good to you, but that is correct because we are suffering from that. So that is the thing actually. We are not the problem, we are solution. Rather.
I remember one of our community TB affected people, Nandita Venkatesan. She was on MDR TB drugs and she lost her hearing. And she represented at first UN high level meeting. And she said, even though I cannot hear, but you will hear loud and clear what I say. So I think that's the role. See through your eyes and make it loud and clear for other people to hear that what is needed and what is not needed. Yes, Sumit.
Just to echo what you said, I think the world has kind of taken note of the importance of the TB with children. I think the funders are doing their part. They have started working with companies to ensure that pediatric cases are getting diagnosed with adequate or appropriate sample types. So very soon you will have and TrueNat will be, of course, one of them, but it's not limited to us. There are other companies as well working on it. So the importance of the children being missed has been absolutely noted by one and all, and efforts are underway to ensure that, again, not to just provide any technology, but adequate and quality technology with quality sample type to get these cases diagnosed. So funders, companies, private sector are all working together. Evaluations in various countries underway. So I think we will have solutions very soon enough.
So also thank you so much for that. And we are waiting. And remember also, if they don't, what do? We raise our placards. So keep the promise. Where are you with our pediatric tools and so forth? But above all that, I think my colleague talked about awareness, and we've had a lot of discussion on awareness. Also, those tools should also should come with some applications. And some applications. We want also prevention TB application. We also want self-assessment applications. We also want treatment adherence application, because all the phones, even those that are smart, these days they are also smart. So this will help us also on raising awareness. There's a lot. We cannot just use the the paper-based, the banners and so forth. Anything you bring us a tool so that we enhance our awareness, digitalize our awareness. Thank you.
Thank you. I'll come to Shobha. She's been working in this space for now a decade plus, working with both patients, journalists. They have raised a lot of issues, awareness around that. So your view on how media, journalism, and constituency of journalists can help TV program to move towards both ways. Making government do something things, making community understand, and raising that decibel level so that people who can read and you hear through your eyes when you read. So how can we do that? Have you been successful in some of your endeavors? Yeah?
Thank you very much, sir. I'm a very small fry here, just a drop in the waves of ocean which are around me. But yes, you said, have you been successful? There have been small successes where I have been able to, I got emails from people just reading our articles.
We want your testimonials, experiences to share.
Yes,
share with people.
this is exactly what I'll share now and a little bit more later. And that brings us to the point that media has to convey the message, not what is regurgitated to it, but think, analyze, and then go forward. If you read some of the headlines, a new TB drug is there. The headline says that. That new TB drug is still in the stages of clinical trial. If you read the whole article, if some layperson reads, and this is what happened for even the Beraculin and Delamanid, when I got emails that I have heard there is a new TB drug in the market and where can I buy it? There's some patient asking. So why don't convey false hopes. Yes, convey the hope that it is on the horizon, but it is still not there. So sometimes the headlines are so misleading, and many of them who will read the newspapers, they will not read the whole article. They will just read the headline and maybe the first few lines. And the real crux comes later on. So I would expect the media not to do that. One headline I read was from India. TB patient dies for want of medicines. And I was very concerned. Medicines are there for free. Treatment is free in India. And then the whole story was about that he used to take drugs and the mother refused to give him money to buy drugs. And then the journalist puts it like, because he could not get TB drugs. So these are experiences I have had also of stigma. There was some girl who wrote to me and she said, well, I live here. I don't want to take treatment in the city where I live. Can you refer me or can you let me know some other doctor? I referred Dr. Ashwini Khanna's name to many patients. Somebody was on homeopathic treatment. He said, my wife has got tuberculosis. So I said, I'm not questioning which pathy you are following, but have you got the diagnosis done? That is important. First of all, from where did you get it diagnosed? No reply to that. Also, sir, recently, one of my neighbors, he's asking me, is there still TB in India? And that is why I think each one of us is a community. We say that tuberculosis is an airborne disease. It can, of course, some are more prone to it, because of the social inequities we have in our society. So I feel part of the community. I think all media is part of the community. And unless we have that activism and advocacy spirit in us, we will not be able to deliver the clear messages. Also, upon connecting the dots, we are talking of achieving SDG on TB. I feel the beauty of Sustainable Development Goals is that they talk of integrated and sustainable development of each human being. And we cannot cherry pick on the SDGs. Okay, I will achieve this SDG. We cannot achieve the SDG on TB unless we achieve the SDG on ending hunger, SDG on ending poverty. We have seen what role nutrition and the social status of the person plays. SDG on gender equality. I have also found women being impacted very, very differently sorry for being a patriarchal society, but somebody said TB bacteria does not see male or female. It can attack anyone and everyone. Yes, it can. But the repercussions are very, very different when it is a female patient. I have interviewed, I have visited female in the hospitals, female patient, one girl I interviewed. You talked of Nandita, sir. At least she got an international platform to say her words. That girl had lost her hearing. She was suffering from MDR TB. And she had gone to care for her sister who was married and needed some help, and that sister had tuberculosis. And from there, she contracted it. She will not have a voice. She will never become a TB. She will not be a TB ambassador. So I have to say also, when we talk of TB ambassadors and we have celebrities promoting the cause of TB, a film star getting TB and getting over it is very, very different from somebody who's living in the slums of a city, and you cannot give that example. I feel so media has to adapt the messages which we are giving in the local context. So, and it has to be integrated, connecting the dots. Even in the media houses, we have journalists reporting on health. Then you have so many beats. You have the political beat, somebody reporting on politics. I think politics is the ultimate determinant of health, and you cannot disintegrate the two from each other. So there should be this breaking of silos, and we have to talk of the other diseases. All right, when we have to end TB, we have to find all TB, and we have to, diagnose, treat all TB. But we have to prevent all TB, and when prevention comes in, there are so many other factors involved. So tobacco control, diabetes control, so many other disease controls. So connecting the dots is very important. And also analyzing, as I said, some news comes, there is some scientific discovery. It will not be there for the next few years. Recently, there has been a news, and I have interviewed the persons who have got a mask to detect TB in children. They are developing it. Sounds very, very optimistic. And the child has to wear, because in the case of children, as we know, diagnosing TB is also a big problem. It's not that easy, even. So you wear the mask for 15 minutes, and then they will collect, they have some film there, and they can diagnose it from that. No need to collect the sputum. But that will take at least 4 years to develop if everything goes well. They are doing small studies before it comes in the market. So good to know such a thing is there, but not good to propagate to the public that that is available, or not put our messages that it is available. I think I've spoken too much.
No. You can actually say a lot of things. We'll come back to you. Let's come back to Professor from Bangladesh. We have not touched on the second SDG, which is reduction in mortality. So what do you think we need to do to reduce mortality, and what is the lessons and any Bangladesh examples you would like to give on reduction in mortality and the activities or the interventions that you do for the same?
Thank you, Dr. Kuldeep Singh. So your nice questions. You know, Bangladesh is among 30 high burden TB and MDR TB countries in the world. So our TB incidence now still 221, and it is it is a challenge for us to reduction the TB incidence. You know, the HIV positive TB incidence 0.43%, and MDR or RRTB incidence 2.9, and the mortality rate in 2022 42,000. That means 25 per lakh population, and HIV positive TB mortality minimum 0.1%. So it is our big challenges how to reduction the incidence rate and the mortality rate. Mortality rate is gradually a reduction. You know, 2015, it is 45 per lakh population. Gradually, year to year, it now 2022 and 2023, it is 25 per lakh population. But incidence rate is so much high, still the 22 to 1 in several years. So it is big challenges. Our diagnostic network or molecular diagnostic network is, I believe, is strong because our digital X-ray, portable digital X-ray, and LED microscope, always, as well as the TUNAT and GeneSpot machines are situated in all the countries from community level up to medical college level. You know, our RTRL, that means NTRL, National TB Laboratory Reference Lab in Dhaka, and others RTRL, our 5 RTRL in big division, and our district and Upazila and union levels laboratory, that means peripheral laboratory is functioning in root levels. So our big challenge is awareness develop in the community level people. Our community clinic and our health assistant, community health workers, and others peoples. We previously discussed the PPM, private public partnership or private public mix. We can try all together, GO, NGO, and private sector togetherly. If we act togetherly, I hope you achieved our target. That means SDG target 2030. We will achieve. Thank you.
So mortality, it is also said, is one of the easiest target which most countries can achieve related to SDGs. I mean, if you treat everybody, detect them early and treat them well, one of the easiest target to achieve is mortality. And the only challenge there remains about missing cases. So if you can find all missing cases, treat them well.
Yeah, our government always trying, if you know, our diagnostic cost and the treatment cost is completely free from government cited. You know, our first line drug, of all the first line drug procured by government, and the other facilities, diagnostic facilities, also free for each patient. So it is our government support. And our others NGO partners and private partners also, they are our implementing partner, and we act togetherly to NTB target.
So that's what I was coming to. Mortality. So far as national programs are concerned, all countries within the program, the patients you detect of TB and treat them, the mortality remains around 5% or less than 5% or slightly above 5%. But it is the private sector or the patient which you have not reached or the unreached patient where the mortality is high. There the mortality, the WHO modeling says reaches us somewhere around 20%. So 20% of patients who have not been reached will die. Whereas under the program, you have less than 5% who will die. And another crack in the gap is that once you have declared a patient cured under the program, 5% of them will die within next 6 months of being declared cured because we are not following them. Though there are policies that follow them every 6 months at least for 2 years. And that is where Sumit, the gap is in diagnostic, both X-ray and molecular tests where they have not reached or where they have not actually positioned themselves after cure. And you see a lot of them, 10% relapse. So if I have treated 2 million patients, 200,000 are likely to relapse, 100,000 are likely to die post treatment after being declared cured. So you also need to follow them. So I'll come to Professor Jaloba, who's an academician and an intelligentsia. How can we plug these gaps? How can we reach out to private sector more? How do you think programs can reduce post-treatment mortality and relapse?
Well, you really touched an area which has a big gap. But going back to I'm sorry to disagree with you when you say that the case fatality rate in pro is about 5% or low. No, actually, in our region here, when you clearly look at the case fatality rate, is in the range of about 15%. Yeah, which is really very unacceptable for a disease which is curable. And as clearly we articulated yesterday, this is an issue of delayed diagnosis. People come with advanced disease. By the time they come, you have no time. That's why there is no room for saying, come back tomorrow for result, refer samples. That patient will not survive. And actually, somehow we observed some worsening in mortality with the coming of molecular tests. Why? Because the microscope was closed. You could get an answer then and put people on treatment, the severe ones. But when you begin to refer the severe ones and you wait extra 2 days, if you're a person who has managed TB, you know what is going to happen. And if they have comorbidities, it worsens. So coming from that perspective, therefore, I like the patient-centered, community-centered. Please put the equipment there. And I really wonder, usually TB people are never ambitious. We are questioning ourselves, they are true not cost too much. But we lived in the HIV era. We saw CD4 machines, PIMA, everything went in. There was no questioning of what? We are trying to save patients. But then you are arguing $10 for what? So that said, in terms of, yes, true, I think it's now we are realizing about the post-TB in bracket care, and we as it is rather than actually the mortality, but also the morbidity. Those people are not able to go back to their normal work, the lung functions, have other complications. So I think it is really very important that the cure should be put in a bracket. Are they really cured? Cured of what? And they are likely also to have, even if they are to relapse, again, they also have TB, many of them. So I think programs are waking up to look at post cure, to follow up those people for two years. Unfortunately, that's not yet where it should be. And I think we should really highlight it so that we don't miss out after we have even invested a lot in the beginning. Thank you very much.
Thank you. I think you brought out that point very well, which I wanted to bring out, that we are trying to reach unreached. We are trying to go to newer places, a lot of innovations, but we have reached a substantial number of people and we are not reaching them again. They are on our radar. You have to reach them again after they have completed the treatment. So I don't think most programs are doing that. And that's contributing to additional deaths, additional incidents for the next year. So I think there is a captive or a population which is under your radar, under your scanner, but you're again missing them. Because you think you have reached them once, you put them on treatment and that's all. My job is done. Your job is not done. Your job will finish after 2 years. When they have completed their treatment, you have to follow them for next 2 years to see that they don't undergo relapse, to see that they don't deteriorate, to see that they don't actually die. That's a very important group of patients. And it's, if I say there is an incidence of 10 million in the world, 8 million, Sahu was saying, have been detected this year. So you are running after that 2 million, but that 8 million you are forgetting because you have reached to them. You have to keep on reaching them till they are finally through the radar. I mean, finally off our radar. They should be off our radar after 3 years or so after the treatment. So keep on reaching to them. Also, we didn't, you also raised, Professor Moses, an important point of advanced disease. And we introduced what is known as differentiated care. So, and put in some criteria. People who have certain level of advanced disease should be given more intensive treatment, more intensive monitoring right from the beginning. Dr. Chopra, Dr. Khanna are also one of the architects of those guidelines. So I think all programs need to separate out their patients into 2 groups. One who are more prone to do bad, one who will do well. So you have to put in certain criteria, which patients are likely to fail and which patients are likely to sort of do well. So less intensive monitoring on those who are likely to do well, but more eyes on patients who are likely to not do well. And again, they are under your radar. You have already searched them. So don't miss them and let them go. So that's an important finding which Professor Moses has brought about. Thank you. Now, coming to again Philippines, Dr. Motera. I saw a very interesting concept in Philippines called iDots, which is I is not internet, it is integrated dots. It means patients of every type, drug sensitive TB, drug resistant TB. We are whether mono-resistant, multi-drug resistant, extensively drug resistant, totally drug resistant, they are offered treatment on the same spot, which means you have decentralized treatment to an extent. And dot centers in our countries are at a population of less than 1,000. I don't know about your country. So while we have 25,000 microscopy centers, but we have 500,000 dot centers. So treatment you have decentralized to that extent. But when it comes to diagnostics, you are still so much centralized. Is there any thought, can say, let's coin a term called diagnostics, integrated diagnostics, and which is again, which will solve the question of access. Did you ever think about that? What is the point in having iDots if you cannot diagnose the patient? So for diagnosis, he'll go 200 kilometers away or 300 kilometers away, come back, and then you give him the treatment. So in that way, this policy has some cracks in it. How do you propose to fill those cracks?
Yeah. So before, when we still call them DRTB facilities, where you can only offer diagnostics for DR if you are a DRTB facility. But we are trying to move away from that concept through IDOTS. IDOTS is the treatment part, but we would like to decentralize testing. That's why we would like to make sure that at point of care of patient's choice, real-time precision medicine testing should be made available, not only for those who are potentially DRTB patients, because at the end of the day, you might be dealing with a de novo DRTB, patients who acquired, they did not acquire drug resistance because they had previous treatment, but they have acquired because it's a primary form of resistance. So the only way to really reduce all these catastrophic costs and patient burden is to make sure that we diagnose them early and make sure that are we going to give them DR or the STB, and making all this testing more readily available and affordable that will actually address all the consequences. Now, treatment, IDOTS is really addressing the treatment part, because it's not, you may be able to diagnose a patient, but you should not treat them. You have to refer, because the second line treatment is not yet really, is still restricted. So that's when we allow testing left and right, but we do not allow treatment left and right. We do allow for the STB, as long as you notify them and treat them according to standards and protocol. But for DRTB, we are more strict with that. And to support IDOTS, we have come up with what we call ETB-MAC. It's an electronic platform where we actually discuss about case management. So providers, whether they are in the hospital or at the outpatient, they can refer difficult cases. Like, I am a patient with comorbidities that I cannot control. I may have I may have TB with with severe reactions, or I have a difficult DRTB case. So we do not allow physicians to just, deal with them, but we actually allow them to refer to specialists, but in a more structured online platform where treatment can be given, guidance to treatment can be given, at the same time allowing patients to stay where they are. So that's where we would like to beef up. So IDOTS is really something that the primary health centers have shunned away. They really are resistant to it. But in the past few years, we gradually taught them on how to set up IDOTS and to make sure that it's really community-based. So we're looking at community-based networks to treat not only DSTB, but also DRTB, because we would like to keep patients where they are and allow them to return to the community to be more productive.
Thank you. I know there are gaps at the present, but this is an interesting idea, which needs to be actually picked up by community and the journalists. This is actually what will actually bring healthcare at doorsteps. You will see many media articles, they think the drug is not available. Nobody says diagnostic is not available. And if you sort of replicate the idea of IDOTS into iDiagnostics and develop that concept and fill in the gaps which are available here, I think that's the true point of care, healthcare delivery at the doorsteps. And I think most programs need to work on this. It's an interesting idea. They can even approach donors on this. How open would you be to this idea? Yeah. Okay. Okay. Yeah, please.
Okay. Okay. Thank you for giving me the opportunity. Anyway, the thing is, what I was just thinking, why they are missing their drug. Actually, there must be some logic behind it. Maybe some reason behind it. Maybe time constraint. That is why they are not coming to the facility center. Maybe drug usually they are taking, but it's not what I'll say. It's not working. I mean, it's not. I mean, they are vomiting something kind of thing, or any other reason might be there. So what I think, what I was just thinking, we should identify the cases actually. So according to the case, we need to resolve the problem. If it is not taking drug, then it is a required motivation, and for that counselor will do the work. And if it is time constraint, then what we did in the during COVID period, that time if, lockdown was there, so we took ART and ATT both and restrict to the doorstep of the client. So that way you can do, or or maybe we can utilize ASHA worker, maybe the link worker also, so that they can take the drug and give it to them. So that
So
these are
that is
the
what I'm saying, what has fallen through cracks of community activists or community leaders and journalism, media, is that there'll be many news on shortages of drugs not being available even for a single patient. You also raised that issue. And in COVID also, I've seen the government made arrangements to ensure that drugs reach their doorsteps. The same kind of movement I do not see for, because what is rational treatment, or how do you prevent antimicrobial resistance? You can't give drug if you don't know what the patient is suffering from.
exactly.
You can only give drug, the right drug. I mean, you can give some drug, but the right drug you can only give if you know what disease he has. And I don't see any movement on diagnostics at doorsteps. In your case, you also thought of only eye dots, not eye diagnostics at doorsteps. I'm just throwing an idea, and I want to hear from the donors what they think about it.
So the first thing is the TV community, excluding our, media advocates, we neglected the big voice for decades, the media and the TV community and the community itself, to advocate for not only for treatment access, for diagnosis as well. It has never been in their agenda. And correct me if I'm wrong, the media people and the TV community as well. If you compare the advocate group in the TV sector to HIV, they are more friends to us, If you go to the HIV, in any conference you go to for HIV, so they shout loud, reduce price, access to diagnostics, access to treatments, and they never been friends. In one of the countries, I was surprised, a TB survivor community was awarding the minister for a good work. For me, that's an insult for the TB community. For a high burden country where you have 100,000 people dying due to TB every year, awarding a minister for good work in TB is a big insult. So with this reflection, I mean, if we want to achieve the end TB targets, we have to fully implement all the existing strategies, fully. Even with full implementation, I doubt it.
Yeah, of course.
We can take an example of India.
Yeah.
So you guys targeted 2025 to end TB, to eliminate TB in India, with the biggest commitment ever in the world, with the Prime Minister championing it. Are you able to do it? So there is an extra thing that is required as well.
Yeah.
Even with full implementation, that's not going to be possible. Look at India. It's only Goa who phased out the oldest, the most rudimentary. It's like 150 years old. Microscope is 150 years old. That's doing molecular testing. I, as a public health expert and a clinician, I expect even the world to come up with, not with WRD, but with RDT that can be done by a community health worker. It's like a chromatography, a paper that you do a test at home, then you know what you have. That is even required to in the TB, let alone placing rapid technology that the molecular tests to every health facility and to the community, to the people. It even required investing much on research and development to have the easiest, the simplest, the most sensitive diagnostic tool, the less toxic, a shorter treatment option. Without that, I think we will be having all of us together meeting every year, year after year with TB. So for me, it's not an option. If we have to end TB, as we committed in 2018 and 23, we need to invest more to fully implement it. By full implementation means phasing out microscopy at least now. Without phasing out microscopy as the primary diagnosis, don't ever think about ending TB. And if you see globally, the US government is the most, I think the biggest donor to expand diagnostics, either through Global Fund or bilaterally. If you consider Ethiopia, if we consider Global Fund combined USAID, 100% of the equipments are brought by USAID. What's remaining is for the rest of governments leaving their commitment. We're committed to invest, but we're not living it. We're not walking the talk. So we should really narrow the fund requirements by mobilizing local resources, including treasuries and other donors as well. So for me, full implementation starts by phasing out microscopy from every diamond health facility. I stop here.
No, you brought out a very important message that we need to completely 100% replace your microscopy with rapid diagnostic tests. And yesterday there was a discussion. This does not mean closing microscopy centers. Microscopy centers will remain. We need them for follow-up. We need them to follow treatment. So instead of testing on day 1, they will test on day 60, day 120, day 180. So microscopy will remain. Microscopy is not going anywhere. We are just replacing microscopy at day 0 with molecular diagnostics. And that is what is needed. So I think let's be very clearly understood that we are not saying close down microscopy centers. You need microscopy. You need that for a follow-up. So very important. I'll come back to you. A very important message. So allow me a little time. Shobha, what do you think about the new idea of integrated eye diagnostics? And do you think it's feasible? It can be done? There'll be some traction or voice for it?
Yes, I mean, anything, and as has been said, for full implementation, we need integration. And it has to be integrated, treatment as well as diagnostics. And in fact, this we have been saying for so long. Upfront, DST should be the norm of the day. And in fact, Dr. Mario Raviglione, so many years ago, he said, it's a clinical malpractice if you do not do that. And we are still not doing it. So that eye dots, and not just the dispensing of medicines, but also of diagnosis. And very important that you do upfront DST. And now we have the tools when we can find those patients. The patients are not missing. We are missing in our zeal to find them. We don't want to go to those places. And Dr. Chopra knows very well the people with whom he is working in the city of Delhi, which is the capital city of India, there are certain pockets which nobody would like to go where there is a lot of TB. And what to talk of other cities. So I think that is very important, and media should be talking of it. And we have a lot of media stalwarts here in the room today, and they are doing their bit. They are doing their best, but it needs more traction and more education of the media also. Very often we read some news, and as I said, we have to analyze even the reports which we get. The WHO Global TB report is a marker for what is happening at the global level. But what local action is needed, what is happening in our own country, we have to analyze that also. See last year's report. So just saying, and slogans are very good, sir. We have got beautiful slogans, but slogans alone are not going to help. Also, the messaging, even if I'm digressing from what I was supposed to say, we are saying that if you have 7 days of fever and cough, go to a doctor. Good. You know, your survey and so many other prevalence surveys have showed that almost 50% of the cases, they are non-symptomatic. So by the time that person is getting the cough or the fever, I think a lot of damage has been done, and that is where the role of active case finding is. What community-led organizations are doing, what NGOs, community-led NGOs are doing. And we were talking of TB and HIV. I don't want to compare, but I think there is a lot of treatment literacy in people living with HIV. And in TB, there is very little treatment literacy. And that is why we are not trusting the patient. We are saying DOTS is very good. I have nothing to say against DOTS. Eat the medicine in front of me. We don't trust you that when you go home, you will eat it. I think if they are made treatment literate and they are told what would be the consequences, more counseling, I'm sure that, and that is one place where we are lacking. In fact, some years ago, I went to an ART center, and some women, they had come, like that was the main center catering to many villages in a metro city. And I was talking to her. She said, you don't tell me, I know what medicines I'm taking and why I have to take them and when I have to take them. And I was surprised. She was an illiterate woman. But that sort of change has been brought by the activists, advocates. I think we need that sort of treatment literacy and then having faith in the patient that he or she will be taking the medicines if told properly. Thank you.
Thank you, Shobha. Now we'll hear from you, Tariro, and then a recorded message from Blessy Kumar. And then I think we'll hear from our participants, their suggestions, comments, and questions, and then in the end try to conclude. Tariro, please.
So thank you so much. So what we need as communities is the language for us to amplify that voice, for the government, political will, budgets, and so forth, global fund, and so forth. We sit in global funds where we see the so many microscopic, but if we don't have the language, then things will not work. So I'm just saying, give us the language. For example, why not microscopic? And why molecular? If I have that language to say, no, one molecular on our GC7, why? They will ask why. Because it's responsive, it's sensitive, it's specific, it's quicker, it detects even other things, something like that. When we go to centralized versus decentralized POC, if you give me the language as community, I can say something on that table. We don't want only to be on the table. We also want to have the menu. Being on the table is something else, but getting the menu is another thing. So give us the language. Single disease testing, then we say, no, this is mild. We have got comorbidities, especially people in the HIV and AIDS. That's why we need these tools. On sputum, I had the worst experience of my my life when I was a program officer for HIV-TB collaboration. We go door to door collecting sputum. They go to the lab, they were not quality and so forth. So you say by the end of the day, what am I doing? Eh? You spend all this time in the village collecting sputum. At the end of the day, no, your sputum, they did not go through there. So why do we need these new tools? Then you can say, well, no more sputum. No more sputum. It's just a swab and things are done. Then on healthcare based and community based, I think we have talked a lot of that. And focus on test accuracy. It's about yield and coverage. It's about yield and coverage. So if communities understand this language, then at any level, we can make that noise HIV people can make. But if we don't have the language, remember, it's about money even on the table for global funds. How much money should go to the lab and so forth. But if we don't have convincing language to these tools as communities, we will not win. Then the last one, the dollar. All these old tools, they are very high cost, but low volume. Isn't it so? And so most of them, if they break down, you have to wait for 2 months for someone to fly to Zimbabwe to come and just to switch something. But we are saying now, for these new tools, lower cost, higher volume, and they are being manufactured in the low and medium income manufactured. So all this advantage, if you give us all this language as communities, then we can advocate at any level. We can go even to USAID, we can go to donors with this language. So give us the language. Then everything can be done on the new diagnostic tools. Thank you so much.
Thank you. Sumit, then Bless's video, and then we'll open up.
Yeah. Just on the language, we've been using this for a long time for our programs. Why molecular? Simply because genes don't lie. So use this language and say, we don't want nothing else. Yep, that's what we are detecting. Yep. I mean, that's a suggestion. I mean, you can adopt, you may not. Talking about his statement of where he said that US makes majority of the funding. We were in US a couple of weeks back, and the TB is on the rise in the US. So another food for thought. And lastly, sir, Dr. Sachdeva, sir, you mentioned how do we treat something that we don't even know. So I've been in the laboratory space for more than 3 decades now. And there has been several clarion calls in the laboratory. We say something called evidence-based lab medicine. You know, the labs are vital. So I think that same concept needs to come into the space when we talk about tuberculosis diagnostics and thereafter treatment. Because if the first part of it, which is diagnostics, is not adequate, not proper, then everything that follows subsequently will be grossly inadequate. That's all I had to say.
Yeah. No, thank you. I mean, that's the first step, even in prevention of antimicrobial resistance. So diagnose correctly and early. Let's play Bless's video.
And what is needed for engaging communities. So when you look at the patient pathway, a correct diagnosis is the foundation on which the whole TB response is formed. If we can't diagnose, why don't we find the people? So if we find the people, we need to be able to diagnose them and diagnose them right so that they can be treated. We talk about the people-centered, rights-based response, and part of that is actually to ensure quality diagnostics. WHO recommends molecular diagnostics. should become a reality for everyone who has the symptoms of TB. One of the things is unpackaging and translating some of the guidelines, the policies that come out from WHO and other places so that it's understood by the community. Otherwise, they will remain on a shelf somewhere. And I think even for activity programs, it's important to unpackage that into a language that's really meaningful, that it really resonates so that there is ownership by people who are actually reading it. And this is being practiced in the HIV movement, and I think we need to bring it more rapidly, more actively into the TB response as well. And I want to share a little success story of the Global Coalition of TB Advocates. We started about 2 years ago coming up with a community brochure on TB preventive treatment. And we found that it was such a big success that we trained people from Asia, Southeast Asia, Africa, and we also translated the community brochure into 8 to 10 different languages, and then the communities from different countries went on to translate it into their own languages. And I think because of that success, we wanted to do it for diagnostics as well. So in partnership and collaboration with Molbio, we developed a community brochure on TB diagnostics. And we did a sample brochure. We printed out a few copies. And after training for on TB diagnostics, we had about 30 very energetic young people who we then divided into groups, gave them all the brochure and asked for their feedback. We were really blown by what they came up with. And there were some really concrete messages that they wanted included. They wanted some changes, starting from the cover artwork. Because as a community, they looked at it and they said that it wasn't inclusive because there wasn't a representation of a person who was differently able. Or there wasn't a representation of the genders and all its diversity. And then they were so excited about the True Act too, that they said, why haven't you highlighted it much more than what you have done in the brochure? We would like it to have a very prominent place in the brochure, talking about the point of care diagnostic tool that it is. So even though it was a long process, it probably took a lot more effort, time, because we had to come back and redo it, get the artists to redo the artwork. What we ended up achieving is ownership by the people who came for that training, who actually looked at it and gave us those suggestions. And I have no doubt that they're going to take this up. They're going to own it. They're going to feel like they were part of development of this project. And I can assure you that they will use it. So to ensure that whatever is developed at a very top level, to bring it down to the ground level, to be meaningful for people at this level, we need a lot of in-between work. And I think that's a goal for experienced advocates and organizations like the GCPA to keep doing. And part of that access also means access to tools in a language that is understood. Whether it is development of TB treatment regimen or tools for diagnostics, along the patient pathway, we really need to ensure that people that we are, responsible for, that we say we represent, need to understand in a language that they feel comfortable with. So unpackaging, putting out there, getting the input from the community is crucial in ensuring that this happens. So thank you very much. And to end it, I would say, by the people, for the people, by the community, for the community, is the key word that we need to keep in mind. Thank you.
But I think we'll now ask participants for their comments, suggestions, remarks, or questions. You can ask question to any one of them. In the end, each panelist will have to give one take-home message towards achieving SDGs, and don't repeat the message of earlier panelist. Okay, let's first over to the participant. Yes, madam.
Thank you. This is Dr. Rupali Shishir Banu from Bangladesh. I have some points and recommendation regarding the community engagement and your points in relation with the post-care follow-up of the TB patient. Actually, this is the missing link. We don't have any programmatic intervention or engagement of targeting the post-TB. So one of the good models Bangladesh has demonstrated, that's the Cure TB Club. So we have to somehow meaningfully engage the post-TB patient so that they are within the programs. And we can utilize them as a peer support group and link them with the community rights and gender action plan. So their engagement will have a link with the programs, and later on, after 1 year or 2 years, we can now think about the impact evaluation. We can do the impact and can follow up. So one of the key programmatic actions, we can take care for the post-care follow-up, and that will motivate them, and then we can, any kind of disaster, health issue, we can address, and they will be privileged so that they will be supported by the social support or any other social safety net programs of the government. So in such way, we can reduce and, track those post-care patient. Secondly, that's another issue that we are now focusing on the NTB, but one part is gradually missing from the programs and by the donor attention as well. That is the social, that's earlier it was ICC, BCC, now SBCC, behavioral change communications programs. So right now, our experience in Bangladesh that from community to professional, everyone thinking, if you don't have a raise in the, you are promoting that for the media, but where is the programs? Like for the HIV program, বাঁচতে হলে জানতে হবে. There are so many, mass communication message. But the TB, it is now missing that social awareness, and donor are telling recent days that is the less impactful program. So this is a great controversy for me as a professional, how it could be less impact program. But it is now giving one of the message that people are forgetting the TB from the community to a professional body. People are started to thinking there is no TB even, because there is no voice regarding the TB awareness is now missing part. Where there is a great demand of the program in terms of the diversity, so many diversity, new concept, new technology, but we are failing to give the message to the community. So how you can ensure the community engagement? That is one of the point, and we want to bring your attention that people are actually missing, forgetting TB. And we can take the lesson from the COVID. What happened, how we were able to engage the corporate sector, private sector, because from that highest policy level, political commitment that everyone has to engage for the COVID. And so we were able to, and there was a we were not, that there was no planning meeting, but fund was coming for the COVID. So that kind of political commitment and the donor attention as well for engaging and creating the awareness, mass awareness, and to translate this very terminology that people don't understand our ambulatory, they don't understand the latent TB, how we can make it more user-friendly community translating message and can generate the message to the community. only then we can ensure the community engagement. So I will really beg your attention from that, take a message from that, that we have to take priority agenda for making the awareness campaign and such kind of issues in the program component in near future. Thank you.
Thank you. No, you brought out very important points. Advocacy, communication, or behavior change communication is a very important part, and I urge most programs to take it forward. Your concept of TB clubs, it's very popular in HIV space. They have HIV clubs, and it helps a lot. So it's like morning walk clubs, joggers club or something like that. So say there's a club of 50 joggers, and if 2 people didn't turn up, they'll go to their home, shout it out, and bring them to their club. Same happens in HIV. If somebody is missing a dose someday, they'll go to his house and say, why didn't you take the dose? So same thing can be worked out in TB. It's an idea, good idea for other programs, especially for post-treatment follow-up. Have you got yourself tested again? Have you followed yourself for TB? I mean, have you been now screened for X-ray? Have you tested? So the protocol is 6 months, 12 months, 18 months, 24 months after treatment. So 4 times after you have been declared cure, you still need to follow. It's a policy even in India, but not actually strictly implemented. Maybe this is a good way to do it, but yeah, thank you so much. Yes, Dr. Chopra. After that, we'll come to you.
Regarding community participation, one thing is very important. We should build capacity of the community also. Many times community is not aware of their rights and what are the facilities available. As I gave my example in my presentation, whenever we go in field and ask them, have you been told that TB services are free? They say yes, but where it is free, where they have to go, they do not know. So community should be made aware of the facilities, their rights. Then comes how they can raise their voice.
Yeah.
Every patient is not Nandita. Everybody doesn't
No,
get chance.
fully agree.
But where they agree, when it was said that there is drug stock out or even diagnostic stock outs, where they raise their voice. There may be some platform, online platform or some portal where they can write out this. Second point was there is a huge difference between HIV program and TB program. Madam Shobha Madam has just told, even my experience in my studies of all active case finding, except for none, everywhere I use NGO working in field of HIV. There was no, I could not find any NGO working in this that area who was working for tuberculosis only. And second point, she raised that we have faith in HIV patient. They take regular drugs. They do not apply that like dots. So either community should be aware, and even patient, we should have trust in patient also. The only point is we have to convince them, tell them what is the problem of the disease. If they do not take treatment, they may become MDR. And one point is your children can develop the disease. And patients are very touchy about their children. So if we give them health education, there's no need to go with all the patient all the way to DOT center. So there must be role of NGOs in TB field also. And for community awareness, one suggestion is, as we are following in India, we are making TB champions. They are old TB survival. So they have got sympathy for patient. They know what is the process of getting diagnostics and disease, what are the rights of the patient, where they have to appeal if they have got any problem. And point you are raising time and again, that is the post-treatment follow-up. TB survival can help in the post-TB examination also of the fields. Thank you.
Yeah, thank you, Dr. Chopra. Again, reiterating those points. I mean, I was bringing out a point that we rush to find new cases. We rush to, but we miss what is there in the existing set of people. And we know their address, we know their telephone number, we know where they stay. Yet we do not reach, we forget them after 6 months. Declared cured, forgotten, off our radar. So there is a huge scope to increase your case detection, reduce morbidity, mortality in that space. Point well noted on engaging community, capacitating them. Yes, most programs should be doing that. Yes, Doctor.
Okay, thank you, the panelists. Just I want to raise 2 points maybe. There is a paradox from the global for example, from Global Fund and, the countries can procure molecular tests because this is new technology. We have a lot of medical equipment. We have X-ray, we have ultrasound, and so on. No one asks about the number of these machines or utilization of these machines. But when you come to the molecular tests, how many gene experts, how many true rats? Why? This technology should near to the community as much as possible. Why we asked for its utilization? Specimen transportation is very difficult. The transportation, the road is not there. Sometimes for vaccination, Ethiopia uses helicopters, by the way. So how can we transport such force in such conditions? So we have to procure machines for that specific health facility. Only one health center maybe in that district. Therefore, they said molecular tests should be expanded. The tests should be using molecular tests. But they asked us, why you procure a lot of machines in other way? Why? This is paradox to me. So as to me, countries can procure as much as possible. This technology should be near to the community. Just, by the way, for the last 135, starting from Robert Koch, we are using a microscope. It was a new technology at that time. So when we construct health facility, we provide coach, we provide other medical equipment, we provide microscope. So still, this new technology, due to the time, this technology should be supplied with for new health facilities, even. Because this is technology, this is the time, okay? This community should be used it. Maybe, Mr. Summit, if there is a space for the cost negotiation, because the other companies like for SafeAid, there is a negotiation for low and middle income countries with high burden TB can have some negotiation for reducing the cost of the machines and the supplies. Is there any space? Because to expand these technologies, budget is very important. So is there any negotiation with countries or with such organizations? Thank you very much.
I think before Sumit replies, I'll come to you. Yeah. The justification actually you can build in on cost effectiveness models. So it's not only the direct cost of the machine or consumables, it's also costs of lives saved, costs of benefit of detecting additional cases, how much of disability adjusted life years. We generally do modeling on those grounds, and it's easier to convince the policymakers. And then the indirect cost saved, which is you save costs by, you are reducing cost to the patient. Indirectly, you are reducing cost to the health system. If patient is not traveling, that is a cost saving to the government. So you develop models like that, we can help you. We have developed many models like that to show you how you show cost effectiveness of a technology. That's how Dr. Sahu presented you in his talk. He said $1 invested in TBs gives you a return of $40. So build in these are cost effectiveness models. So they are not it's not direct costs. It's also indirect costs. It's also showing them it's the system cost. To a country, what matters is the total cost, not what you are spending. What he's saving is also, that's an earning on that ground. But I'll leave it to Sumit to respond. Yeah. Question was to Sumit.
No, I completely echo your thoughts, Dr. Sajdeva. But coming to you, yes, we have got LTAs with the global funders. And these LTAs have been arrived at after some very stringent and some very lengthy negotiations. Keeping something long, very short, there is, I would say impossible is nothing. So there is always a space, provided there are visibilities. If the, business is all about the volumes and then the prices subsequently coming down, right? So if there are realities and visibilities for a product manufacturing company, cost can always be a flexible option. So for the moment, we have the LTAs with all the global funders, and we have kept that option open as and when the scale up happens, we are open to relooking at costs.
And yeah, the first talk in today morning was also how to explore other sources of funding. So you can do that. You can have a 1:1 discussion, learn that over a period of years, you will be able to at least get 10% additional funding from non-traditional people. You will be able to do that. It will not happen tomorrow. It will happen over next 1 or 2 years as you start doing that. It's not. Yes, Amitava. You wanted to say something?
Thanks. I guess from a journalistic or communications perspective, there are a lot of glaring gaps that we need to quickly fill. There are still pockets where, the basic awareness that what are the symptoms, that diagnosis is free, treatment is free. There's a acute lack of awareness. There exists a lack of awareness about if you start on a treatment, what are the side effects that you could expect, the importance of continuing with the treatment and finishing and completing that treatment. So I guess from those gaps need to be quickly filled. So since we were talking about
fully agree. I mean, every country program has to look at those components of communication. Any other? Yes, please. Bobby, there. And then we'll come to you.
Thank you very much. I have 4 things to say. One of them is about the advocacy of the colleague from, I think, Zambia, Zimbabwe, who spoke about a fight. Just to say that for some of us who manage large-scale programs, it is important to keep the advocacy. And sometimes it is a fight. I'm not saying physical fight, but consistent advocacy, because around the decision-making table where decisions are taken for resources, sometimes we think about what the advocates are going to say. And that sometimes influences the decisions we make around large-scale programs. So the positive defiance is very, very important. So please keep the advocacy going, because that is important. It helps in many, many different areas. I work from both HIV and TB background. The issues of patient-centered care. Currently in HIV, you realize that we've even changed the language, how we are referring to patients. We now say recipients of care. So these are very important things. And so let's push the advocacy forward in the area of TB as well. The other thing that it was mentioned, and I think that it's good for all of us, is trying to improve and provide a language that is important for our justification of resources as we get around the different tables with the menu that you mentioned. This I think is important. And one suggestion I have is that as we get those of us who are involved in program design and proposals and solicitations for large track grants, let's try to include the language of molecular testing at that level, because that helps a lot in the final decisions that are made to enable large-scale procurements and therefore driving prices down. We've done this in the area of HIV. Now we are at the level of molecular, testing with TrueNut and others. So let's keep that at the back of our minds, especially for those of us who are involved in this large scale. And I know there are Global Fund colleagues here, there are PEFA colleagues here, there are other agencies that we represent that make critical decisions on this. And for me, one important observation that is coming through all of these is the whole aspects of social return on investment. For me, I think it's a big driver that can continue to increase our passion and also increase our justification for some of the investments that we need to enable us unite and eliminate TB. Thank you.
Thank you. Tarit is wanting to catch a flight. I given him for him. Okay, very good. So over to you, and then we'll come to you as well.
Okay, fine. So now I'll say now. Now I'm leaving. Actually, the thing is, it's a really good experience to me. I mean, good learning for me actually. So the things which is happening with TB, I saw it from the different countries has come there here, and the representatives all they are showing their practices. It's really a good thing. I learned a lot. And one more thing, I just before leaving, I just want to say one thing, that is there is a global call of to stop TB all, to find TB all, to stop TB. So already near about 600 people has been endorsed. So some that banner is hanging over there. So I am requesting you who has done endorsement, that is fine. Who has forgotten, if you are agree with us with the ask, then please sign. Thank you.
Question for him?
Okay. For B.
Hello. Thank you very much, all the panelists and Dr. Sachdeva, for organizing this type of panel discussion, which is very relevant. And my not question, one query or rather than suggestion to Mr. Torit Kumar Chakraborty, that regarding the language use, because in case of community health, what you told, that without community nothing could be done. Always it has to be accepted. That is okay. But at the same time, sorry, whenever any kind of company materials or stop TB or elimination TB, these type of languages are being sent, if it could be transferred or transformed to the local language, like the DOTS program. When the DOTS program were being initiated during our student life, we saw that all the English terminologies were there in the DOTS center. Slowly it was being transformed into the Bengali, Uriya, and South Indian languages like that. It is one suggestion that as much as possible to use the local languages to engage community more and more. Thank you very much, and you can now feel free, please. Yeah. And now coming to Dr. Sachdeva's one point, I'm taking this very important note that for those, yes, microscopy should not be replaced permanently, but at the same time, where the microscopy test could be replaced by the NAT testing and molecular testing, and especially you have told that 1 or 2 samples maximum, 1 sample, those several sites are there. So in those cases, sir, what we could think of that, and that if there are two things which I can give my opinion based on my experience and working on to those sites, that even we can promote those sites for the end-to-end solution wheel. That means end-to-end solution van, mobile van, to cater all the nearby very lesser workload sites, or even our odd mode. Suppose Monday, Wednesday, Friday, and the localities could have performed the test in the nearest TrueNet sites and NAT sites, and the Thursday and Saturday like that. This is one mode. And multi-disease definitely that could be utilized in case of BPHC. If the one TB test might be, but if another 4 or 5 tests would be there, then definitely one single modular TrueNAT would be then viable for those sites. Now coming to the Madam Sobha Sukla, Madam, what she told, that is fantastic. I like that because I have already heard and faced that similar question. Is there TB at all today in nowadays? So many people used to ask. I can share one data, mention one data recently on program, and the TV authorities have shown that 187,000 people died in India in COVID, and 445,000 died in India in TB. The people always think that COVID mortality was too much more than the TB. That figure explains it itself. That in spite of having the more mortality in case of tuberculosis, the awareness and the whispering and the making noise, and coming to that, related to that, not only everywhere or every the panel discussion programs, this is being emphasized or highlighted, that World TB Day. But what we want to say, that not for targeting only one day in a year, to advocate for the TB testing or TB diagnosis, not for only 24th March for World TB Day celebration. Let us make one habit to say more on accept World TB Day. Language and the brand ambassador and visibility. And the advertisement, whatever would be done, that means suppose on walkathon or any kind of mobile vehicle, this type of things could do better yield. Thank you very much.
I'm just taking up Dr. Sachdeva's place for a moment. Any more questions or suggestions or comments? Please continue. Yes. Please do.
Thank you.
But I'd like to thank Day-3 and Global Fund for bringing community-led monitoring as a strategy, and they are funding that. Some challenging programmers may invest on community-led monitoring. Community-led monitoring has got 4 prongs. It has 1 prong on governance and engagement, another prong on research, where we are monitoring for demanding for services using different tools, scorecards, questioning, and so forth. And also our advocacy is not that making noise. So the advocacy is going to continue because evidence-based advocacy through community-led monitoring, we are doing evidence-based advocacy. It's continuous. We don't have to, and our advocates, they've got levels. Because most of the time, even you say, we come to international conference, but sometimes we bring issues that can be solved at health center level. But community-led monitoring is teaching us even to say which problem is for community level, which one is for district, province, which one is for national, and when I come to an international conference, which problem can be solved at international level. So community-led monitoring is solving most of our engagement and communication between civil society with donors, government, and other, even on planning. It helps us also on planning. And the issue of TB clubs, differentiated care models for TB patients through support groups and clubs, yet their own problems. The patients are at a different level. Someone is starting medication, someone is finished, something like that. But what we are doing, like in Southern Africa, because also we are having a TB in mining regional grant, we are putting different TB KVPs in association. For example, There's a network of TB survivors. There's a network of TB, KP and vulnerable populations. We have a network of ex-miners because as Southern Africa, 17% of our TB is pushed by artisanal miners. We have we are putting artisanal miners in association so that we will be able to diagnose them for silkers and TB. So something is happening, but our key program is community-led monitoring. It has all the 4 prongs for differentiated care models, our governance issues, our communication issues, planning issues, evidence-based advocacy. So let's also invest in community-led monitoring, and our funders are doing that. Thank you.
Good. Any other, yeah.
Thank you. Thank you, the panelists, for a very interesting discussion. My name is Huy Huyen. I'm from Vietnam. I'm now the team lead of the PBM sector at my organization's Friends for International Tuberculosis that fit in Vietnam. So for those who don't have a Vietnam, where Vietnam is, because I asked some staff in the hotel here, don't know Vietnam. So Vietnam is the border in the north with China and on the west with Laos and Cambodia. So in Southeast Asia. Anyway, a few days ago, we have been talking about a lot about the searching. So I, as working in PPM sector, I'm very interested in terms of searching, and one of the obstacles to prevent the good searching is a stigma. So just a little bit more details that before coming here, because living in Vietnam for India, I received a complaint from a private doctor who told me that one of his patients claimed him that why the communal health station knows he's a TB patient, because the communal health station on the VTMS, the system in Vietnam to for data collection of TB patients in Vietnam, and then the communal health station came to his house for household contact tracing. That's a good thing, but because he wanted to hide his information when he came to treat at the private sector. So that's why the private sector claim, because we cooperate with the private sector to help out the patients. So I would like to ask the expertise from panelists and also the other colleagues here, how we can prevent, actually how we can make the patients more confident when they cooperate with us in searching patient, in searching the TB, actually. Secondly, I'm very interested in an INTB, and then how can the company like Molbio can cooperate or can help us to increase this technology in private sector in my country, and some more patients can benefit from this kind of technology. Thank you very much.
Thank you. So on stigma, I think any of the panelists can take here. On the second question, Sumit, you will respond. Yeah. Sigma, I think. Okay, Shobha. Let's hear from.
Okay, thank you so much. On stigma, I think as countries, we are encouraged to have a stigma index so that we understand the levels of stigma in our country across all the KVP in their diversity. After that, then we can come up with a stigma plan, an action plan, and strategies to combat different levels of stigma. For example, in my country, our stigma indicated that most of the stigma was the internalized one, more than what is coming from the environment and other people. But self-stigma was top number one. Just to say, what are people saying if I say I've got TB, other things like that. So we need to do that. Another tool is CRG. We have to do community rights and gender surveys in our country. Again, this will help us to come up with strategies to combat stigma, barriers, abuses of rights, and all those things, patient charters, all those things. So those tools, they are really well funded in a big way by Stop the Partnership at country level, and it helps a lot to come up with the strategies to combat stigma. But without knowing the levels, without knowing, because sometimes we just, these words, we just use them, stigma, whatever, but what is the level? And where is it coming from your country? It might be different from my country. It might be different from another province. The stigma issues in Delhi and the stigma issues in Goa might be different. So once we have those two surveys, we'll come up with very beautiful strategy to at least reduce stigma among TB patients. I thank you.
Shobha, you would like to respond here?
I would just like to add a little bit. What Tariro has said is right, but it is also about reducing stigma in people who do not have the disease, because more often than not, we need them to know what it is about. Also, those who have tuberculosis, and again, there is about spreading the right message and the right information and knowledge. Yes, the person has TB. After so many weeks of medication, the person becomes non-infective. That is important in the case of pulmonary TB, because there is still that feeling if a person has extrapulmonary TB also, the person is separated from the family. Extrapulmonary TB does not spread through the air. It does not spread through your breath. So that sort of information, I think, is required. And for any disease, it's more, there needs to be more awareness in the people who do not have it. As I said, many people think there is no TB at all. And if it is, well, that is a no thing. You just don't go anywhere near the person. Yes, all of us should be following infection control. I think COVID-19 taught us that, but took away the lessons very quickly. We started wearing masks. I find in a place like Thailand, and even somebody told me he had gone to Nepal, and he said there people wear masks to prevent themselves from the cold and air pollution. So masks are something not only for COVID-19 or TB, but for any airborne disease. And in Thailand, I have seen it's become a way. Even I find small children going to the malls, going on the streets, wearing masks. So again, correct information and awareness in all, the TB community as well as those who do not have. I think that is important.
Thank you. Sumit, you will respond to question addressed to you.
Yeah.
We'll come back to you.
So with your permission, my 2 bits on the first part as well. I think post the pandemic, it is incumbent, and I think there are enough powers that be in this room, that TB education starts right in the schools and colleges. We're talking about pediatric TB. I haven't seen any textbook of late in the middle schools where kids have the understanding power to kind of understand what TB is all about. So one is that we can start as a post-pandemic action, that we can introduce, talk about TB in schools. Second, to your question, that the person was trying to hide his or her TB condition by going to the private sector. And I think Dr. Sachdeva has spoken that TB being a reportable disease, I don't know if that's the case in your country. I think it would be. So if when the patient knows that the private sector wherever he or she is going, would also have to report if he or she is diagnosed as TB positive. I think that part of the willingness to kind of camouflage or hide behind a facade would generally go away. But more importantly, I think the education all across, right, from the school's curriculum, probably needs a shift. Now to your question, sir, to Molbio. I can only say this: as a conscious company and a company from the global south, we understand problems that we all have in our Asian and African countries. We have committed ourselves to doing whatever that is possible. And as the earlier question said, and we responded, that we will be alive to doing everything within our possibilities to ensure that more and more boxes reach the last mile, as we say. And these kind of technologies are being used by more and more people, and that's the first case. So should you have any specific ways you think that Molbio can assist, we would be very happy to hear from you and discuss beyond the dais. Thank you very much. Yeah.
Good, yeah. So from Bangladesh, the program manager, and then we'll come to yeah, we'll come back to you.
Just to update you, in this forum, we are taking the opportunity that Bangladesh already developed the did the CRG assessment in 2018 by following the Stop TB partnership and facilitation was done by BRAC. Later on in 2021 to 23, Bangladesh National TB Control Program developed the costed TB CRG action plan and investing around 8 million of fund from the Global Fund, and both the government at the policy level and by the PR BRAC, we jointly had different kind of activities. Within these, there was one of the important activities that identifying the stigma among the TB. So in this current grant, already in the 2023, we completed the study, the understanding the TB stigma among the TB. Following the TB stigma assessment tool of Stop TB partnership, and we identified the stigma at the different TB care pathway from the patient to community, family, system, structure, every level. And we have find out a very good result, and that are now in the process of the finalization by the donor review. And we are coming up with some of the key recommendation. I think that will be very much instrumental, and we'll be happy to share this report with all of you. If anything we have in the linkage that I wanted to share with you. So
sure, that's good news for other programs. Yeah. Yes, Doctor, please. No, Bobby, just behind the. Sorry.
Thank you. No, I want just to bring some few things. Thank you for to share your experience on these community issues in DRC, but I'm pretty sure that is the same in our border country like Uganda, Tanzania, Kenya. We have a strong community engagement since maybe 20 years. And what is important now today, we can clearly show the contribution of community in the notification and also in the treatment success. In DRC, the community contributes at least 30% per year in detection. And for 2023, the treatment success for the entire country was 95%. We can have this kind of result with the community engagement through different approach. As my colleague said, we have this TB club, we have this TB survivor association, we have this NGO working with the NTP. In DRC, the main NGO working with NTP, we are in the same location. So we can work closely every day. And also those two measure indicators are part of our monitoring and evaluation plan. So I guess community docs should be something very important. And before maybe to close this meeting, Bobby, as maybe this final statement, I guess it would be important to show after this meeting or during this meeting that increasing community access to testing for TB should be an approach with clear intervention that I think that with that we can have also good result during the coming year. Thank you.
Thanks for your response. Bobby, this side, please.
Thank you. Thank you to everyone who is in the panel. My question is to the doctor from the Philippines. I didn't get your name correctly. You talked about when you diagnose a TB case and you immediately start treatment. Then the second part, you said you diagnose, but you don't start treatment immediately. Can you please clarify on that?
Okay, I think I communicated it wrongly. Definitely for drug-resistant TB, we cannot, we discourage starting it in facilities where they don't have the capacity. Number one, we have to protect the second-line drugs, so we cannot prescribe them left and right. We have to have a system to make sure that the patients actually adhere with the treatment so that we do not amplify further resistance. But that is for drug-resistant TB. In the Philippines, we have decentralized DSTB, meaning the private sector can actually privately manage their patients as long as, number two, there are two conditions. They notify the case until treatment outcome, and they follow the standard of care. So if they, and if they privately manage the patients, they are required to report the treatment outcome. So if I'm the private physician and I don't like to be liable for the treatment outcome, I'd rather refer to somebody who would take care of the treatment, and I will just take care of the diagnosis part. But in our system, we do not lose patients. If you refer them to, for example, a TB facility, the patient does not mean that the patient is no longer under my care. So the patient can still go back to me to manage other non-TB conditions. So if the patient is diabetic, for example, or has COPD, chronic obstructive pulmonary disease, then I can still continue to manage the patient, but the patient is co-managed for the TB part. So I hope I get it correctly. Even for specialists, even if you're infectious disease or I'm myself a pulmonologist, I do not manage drug-resistant TB. I'd rather refer them to a facility where they are taken care of better.
Okay, good. One or two compelling questions, and then I think we have to listen for a final word from all panelists. At least today, go to lunch on time.
Good afternoon, sir.
Yeah, good
I'm
afternoon.
Shardul Nautiyal from PharmaBiz newspaper.
Yeah.
Sir, we are talking about point of care diagnostics. And since starting from research now, it has come to economies of scale. So what are the possible advancements in the future in terms of point of care diagnostics? And what do you foresee the accessibility of these kind of tools like the TrueNet platform? What is the vision and mission ahead and the accessibility part?
Okay, thank you. Sumit?
So if I got your question correct, you basically were wanting to understand
Future products, accessibility, advancements, and accessibility of platforms. Yeah.
Yeah. So you also already mentioned the TrueNet, which is there now, and which is kind of going to a lot of areas that were earlier not covered. But having said that, Molbio is not limiting itself to only the TrueNet. There are other, as he mentioned, about the simpler tests that remains to kind of as a dream as of now, but a lot of work is going on. We have work in very, very advanced stages of progress in terms of biomarkers that will be configured on a very, very simple ICT, immunochromatography test, which will be very simple. Maybe a patient himself or herself can do it. It'll take very less time and it'll be less costly. Earlier in the sessions, someone also spoke about something which we call commonly as the cuff signature. So those are also going to be technologies that Molbio is going to be investing in. Maybe not in terms of manufacturing directly, but onboarding similar companies and using the Molbio reach to take those products globally. So a lot of things in the anvil. In fact, the product that I mentioned first, the biomarker, is at a very advanced stage of coming to the market. It's already probably being given to ICMR for initial evaluations, and once those are completed, it'll see the light of day. So biomarkers, cuff signatures, AI-driven radiology is already there. You have seen the ProRad Atlas, and of course the TrueNet. And as we kind of progress, the company is going to be alive in allocating resources to any other areas that seem scientific enough and that we believe would be creating impact in the world of TB and, of course, other infectious disease areas. I do hope I have responded. Thank you.
Thank you. I mean, the entire panel will be available even during post-lunch for all of you to interact. I just wanted to sort of let you have today, at least have you lunch time. Any one or two quick questions, then we'll come to panelists for final rounds.
I was curious about the implementation of the essential diagnostic guidelines, in furthering the diagnostic practices. So there is one, this policy intervention, which is required as in terms of implementing of the essential diagnostic guidelines. So something on that, on some perspective.
We'll keep advocating and pushing for implementation in true letter and spirit of essential diagnostic guidelines, which have been developed by ICMR, and we have been part of it. Having said that, I'll maybe Sumit, you would like to add on something?
We are conscious of the essential diagnostics guidelines. We are still in the early days, but as Dr. Sachdeva says, and I completely echo, technologies that we will bring to the market, we will consciously try and see that these are kind of getting embedded within those guidelines. It could be taking us some time, but we will be consciously doing it.
But Sadul, just a point of little difference with Sumit, that future diagnostics may develop their own guidelines. They may change guidelines if they are path breaking, etc. So keep that in mind. It's not that everything comes within a straight jacket and you have to just follow the guidelines. All these new tests actually change the previous guidelines. So these guidelines are not set in stone. If there is a breakthrough technology, that changes the guidelines. Bear that in mind. Okay, you have a question?
Yes, no.
You are the organizer.
Oh, no, sir. We're doing this together. So, sir, very quick comment, because Mr. Hua said that probably people are not aware of Vietnam. I think people here in the room are very well aware of Vietnam, Mr. Hua, because of the 2014 study, which got published in 2018 or 19, which is probably the strongest evidence, sir, where in Kamau, the NTP screened everyone molecular diagnostics. At that time, there was no ultra portable X-rays. So, so they screened everyone with molecular diagnostics, regardless of symptoms. And in 4 years' time, 74% drop in TB rates in Kamau. This is huge. This is exactly what needs to happen probably everywhere, sir. We need to screen everyone regardless of symptoms. In India, probably, you please correct me, I think more than half are asymptomatic. In Nepal, I think 70% are asymptomatic. I think that is a great path-breaking study from Vietnam. So thanks a lot to Vietnam for providing such a strong evidence to find all TB by screening everyone, regardless of symptoms, and linking them to care. And one very quick thing, sir, which really gives me a lot of hope. In that study, children were not included. But because of the decline of TB in the population, the adult population, the decline of TB in children was 50%. So which is another evidence that treatment is prevention and it has a cascading impact towards it.
Yeah, so that's cutting the chain of transmission. We know about that form of study. And actually, in fact, active case finding is a form of doing that. So it's dependent upon the sources. That's what we discussed in achieving SDGs. We keep on advocating for population level screening. But having said that, we also sort of very conscious of the resources each country has and how much of that they can buy, but they should strive to do that. Yeah. Okay, we'll have one final thought from each of the panelists, starting from Shobha, ending with Sumer. We'll go in this direction. Shobha, please, your final words. Achieving SDGs.
Achieving SDGs, as I said, we cannot achieve one SDG in isolation. That is about sustainable and integrated development. And so we cannot do it at the cost. We just can't say we will get rid of TB, we will eliminate TB. But we don't care about hunger and poverty. That is somebody else's domain. And let the other sectors look into it. Gender equality is somebody else's domain. Likewise, education. All these things go together if we have to prevent TB, which is an integral part. Because finding all TB is the first step. Doing upfront DST is the second step. Of course, that is part of the first step. Giving treatment which works on each patient is the next step. And as Dr. Sachdeva said, maintaining the follow-up even when the patient is declared cured for a period of time. But what about prevention? I find 10 people with TB. They all go through this cycle. There are 20, 30 others. And they keep on spreading. So for prevention, it has to be not just compartmentalized, but we have to look into so many other social aspects. And we have seen in countries where the social determinants improved, TB rates fell down drastically. There are so many examples in the world. Western countries, we started with that. Initially, there was a lot of TB, but as long as the social standard of people, they had good housing, good food to eat, a certain level of standard of living, hygiene, TB rates did drop down. Thank you. That is my message.
Professor Jolobaya, your final thoughts.
Thank you. Thank you. I really want to sincerely thank Molbio for bringing us here together. Thank you. Thank you. Because I am happy that the people where the burden is highest are here. And the TB is a disease of the poor, and actually worsens poverty, as we have seen. However, I'm disappointed that I have not seen the ambition in this group. We are not ambitious enough. And I don't feel the fire in the belly in this meeting. When we say, for example, we want to replace microscopy with the molecular test, what does that mean? When you hear a country has 400 molecular tests compared to 4,000 microscopy centers, how are you going to do it? Are you going to build a sample referral system? How is it? What is the cost of that? Do we have a measured effort to achieve what we are talking about? If you can't measure it, you can't achieve it. What do we have to do to achieve this N2B strategies? In our countries, where the burden is highest, this has not been answered. And I don't think we know that. You know, when you don't know that you don't know, then you have a problem. I think we don't know what we are doing. We need to seek answers to end this problem. So what we have to do more, and we are not doing it. So I hope this will not be the end. It will be the beginning for us to be serious. Thank you very much.
Thank you, Professor Joloba. Yeah, we go to Dr. Muhammad.
Mahfuzur Rahman Shurkar. Thank you, sir. Actually, I have nothing to say, but before finish, I brief in short some significant country achievement because TB notification increased from 206,000 in 19 to 2015 up to 301,000 in 2023. The country is maintaining a treatment success rate over 95% since 2015 in our country. TB mortality declined significantly because 2015 it is 66,000, but in 2020 42,000. That means 45 per lakh population in 2015, about 25 in 2022. It is a significant decline, 36% decline. Our procurement of first-line drug from government side, government funding from 2018, and locally manufactured pharmaceuticals company from 2022. Countrywide scale-up molecular diagnostic tools such as GenSpart machine and TruNat machines, including the sub-district levels and hard-to-reach area also. TB preventive therapy countrywide scale-up in progressing well. So it is our significant achievement. 100% electronic recording and reporting tool. ETB manager has been scaled up all over the country and integrated with DSIS2, that means government reporting systems. So it is our main significant country achievement. Thank you so much. Thank you, everyone.
Thank you, Doctor. Really good achievements by Bangladesh. We put that on record and acknowledge that. Yeah. Lalen, we come to you on your final thoughts. Achieving SDGs.
Oh dear. Okay, so I would like to thank the organizers for a very full-packed 3 days. I really appreciate the enthusiasm and the attention for everyone. We have been delaying lunch for the past 3 days, but I see your interest and the intent to really listen to each other, and I would like to commend everyone. Of course, it's really trailblazing to include in one platform, the patients groups, the community, the donors, the technical partners, and the diagnostics sector in one stage, talking about how to make things easier for our patients. 20 years ago, I had a patient who said, I'd rather have cancer than TB. And it was really a very dismal remark. But 20 years moving forward, I think it's better to have TB now because we have better diagnostic tools. It's more rapid and it's precise. We still hope for the shortening of the regimen, but I see hope that we'll be able to make the lives of our patients with TB a better one. So I think future collaborations are very important, and I really commend that we have more to come. Thank you.
Thank you. Thank you, Dr. Motera. Madam Tadaro, please. Yeah.
Okay.
One last. Just say a rejoinder. I know that India was the record holder of the largest human lung formation in 2017. I would just like to inform you that we already beat your record this March 16, 2024, and we have surpassed your record under the Guinness World Record. And that event, which happened last March, was really a very trailblazing event because for the first time, all sectors came together, woke up 3 a.m. to have that magnificent human lung formation in Manila. So it was a very innovative way of of putting the message across that we can do things together if we act together. Thank you.
That's great. Yes.
Okay. Okay. Thank you so much, especially the organizers, for putting communities and enjoying the menu on diagnostics. It used to be called a technical area, but I'm so happy today we are here as communities saying also what we feel about diagnostic. So finding and diagnosing tuberculosis continues to be the most challenging aspect of the TB cascade of care. My take home is let's invest in developing new tools needed to close TB testing gaps. And together we can. Yes, we can end TB.
Thank you that for powerful message. Dr. Cassie, please. Yeah.
Thank you. I'm gonna shower you with politics. First of all, thank you for organizers, Molbio, for having this the Global South meeting. Initially, I was wondering, I was missing the global giants, WHO, the Global Fund, and others. It seems this is more comfortable and very good, but the after action, we should communicate those combined messages to the giants. At the same time, all of our stay here for 3 days should be purposeful. We should take lessons learned from other countries. There are a lot of experience that could be taken for every country. I can point out one thing in India, which is very interesting. Adopting patients for care and support. I think this is possible in communities where the social structure is still intact, and the Global South is a global example for an intact social structure. So I think this is one lesson that we can take. Having said that, I also recommend for all of the NTPs and Ministry of Health that are here to take meaningful and genuine engagement of the private sector. Trust me, you will never lose by engaging more private. We should also meaningfully and genuinely engage the advocates, the media, the community, TB survivors. They will speak your language in front of politicians, parliamentarians, and they will help us to leverage resources. And to end TB by at least to see the end of the light at the end of the tunnel, we should also take bold steps. We should phase out microscopy from primary TB diagnosis. We must, in countries where we are not doing, we must increase our domestic share of investment. Without that, we can't really own the programs. And people-centered treatment is like serving people closer to home. I think this should be a motto for everyone. To achieve all of this, there are no standalone TB service facilities, be it in the public or in the private. These are all in the comprehensive health facilities. So we should take our own share to strengthen the health system. Without a functioning supply chain, without a functioning information system, and without a motivated, retained, and committed health workforce, we can't achieve results. So we should also take a step to contribute to a health system, a primary health care unit. There was this one political question about the expensive rapid diagnostics from my country. So you're planning to end TB by 2030, and you're buying a lot of machines, expensive machines. So if you are ending by 2030, what are you going to do with these machines? What do you want to do with these machines? So if you are ending TB, what are you going to do with the gene experts, with the TrueNAT, with the other multiplex machines? So the message is we should start convincing politicians these are machines, technologies that can do to the minimum 40 plus tests. And we should start integrating it. And finally, we learned from very committed countries. Ending TB is a possible agenda, but it will require beyond fully implementing current technologies, strategies, and interventions. So this is a call for technology firms to think about investing more on research and development, coming up with a more simpler, quicker diagnostics, treatment options, and others as well. This will only take us to ending TB, ending a 200 years old plague. No disease has claimed more lives than TB. Even HIV and TB, HIV and malaria combined are not taking more lives than TB every year. And if you combine it all 200 years, whether non-communicable or communicable disease never claimed this much lives. So let's make TB a priority for everyone, as a multi-sectoral accountability framework agreement is a very required agenda now. I will stop here. Thank you.
Thank you. Finally, last word from you.
Yeah, the experts have spoken, so my job becomes that much more simpler. Just two things. To Prof. Jaloba, I believe that impossible is nothing. To you, genuinely, we'll just do it. And the way forward is collaboration, 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 more collaboration. Thank you.
So from my side, two things. One, all these panelists will be available even during lunchtime if you have any question. Two, the first presentation from Seema, she'll also be available during lunchtime if you have any questions. Before I say, give it to Priyanka for final announcements, let's give a big hand to all panelists. Yeah. Priyanka, any announcements? The panel can. Yeah, okay. Yeah, yeah.
I had the privilege to call Dr. Sanjeva to chair the panel. Now I'm taking the privilege of thanking him for chairing it so well, for hearing us out, and let us speaking our mind. Thank you, sir.
Thank you, ma'am.
Yeah, remain in seat. Oh, okay. Sorry, right now we are using the dining room for a little work. So I just need 5 to 10 minutes. What we're going to do meanwhile is we're going to call you one by one. If you can just go to the back, sign on a paper that Winnie is going to give, and then we'll hand you something. The rest, please stay on back here because the food is still being set up and they've asked to just have a little bit of privacy while they do it. So can you give me the list? Oh, Oh, no.
Sorry? Oh, yes, while we all on the role of media in accelerating progress on the End TB agenda. And I would like to invite, and I'm taking the names in alphabetical order. So there's no first, second, or third. Kalpana Acharya, Editor-in-Chief of Health TV Online and former President, Nepal Health Journalists Forum. Welcome, Kalpana. Nurul Islam Hasib, Senior Journalist with Dhaka Tribune, President of Diplomatic Correspondents Association of Bangladesh, and former National Secretary of Dhaka Reporters Unity. Dr. Tin Mong Thieu, a senior editor from Myanmar, and he writes for the Burmese paper, The Standard Time. Welcome, sir. Viveka Roy Chaudhary from Indian Express, a leading newspaper of India. Zarina Gelu, former editor of The Guardian Weekly from Zambia. So we have a very cosmopolitan panel from 5 different countries. Unfortunately, 2 panelists could not be here, and their names must be on the agenda which you have got. Esther Nakazi, who could not get a visa on time, and Catherine, whose flight was preponed. She was supposed to be here. Her flight was to go at 9 o'clock. I think now she has to go at 5 o'clock. Flight was changed or preponed, but she had to leave. So without any further ado, since there are 5 countries represented on the stage, I would put forward the same question to each one of you, and you will please reply in the context of your country and your personal context. So we can go in any order. Dr. Thieu, maybe we can start in that order first. My first question is, what are some of the guiding points you keep in mind while reporting on TB? Here we are talking of TB only. Yes.
Hello, good afternoon, everybody. I am Dr. Tin Mong Thieu from Myanmar. I am former chief editor of Health Digest Journal, but now I am freelance health journalist. And before I respond to the question, I would like to talk about some points that why media is important for reporting, when reporting about the public health issues. As you all know, the awareness in educating the patient is very important. It must be timely and accurately. So the media is very important to give educating and the awareness to the public. And number 2 is also it is something like the advocating to the policymaker. When an issue is occur, when an outbreak, we must awareness give to the policymaker and how to prevent, how to treat, what are the preventive measures, etc. And also they have the duty to shape the behaviors and attitudes of the people when they are facing with the public health problem. They may feel anxiety or fears of the misinformation. We must clarify and we must talk to the public about the true information. We must promote positive thinking and we must also discourage the harmful facts also. And then in the case of crisis communication, that is very important at that time. The media is very good role and to get operate in time and accurately, and to communicate to the patient for the true facts to the people. And that is very briefly about the media can handle with the public health problem. And when we are going to the journey, to the NTB journey, we are facing some challenges in our country. And first of all, in Myanmar, that is, some of you may also know the current situation. I don't want to talk about much about it. And number one, the challenge is now in Myanmar, there are less media outlets, especially print media and also other media. And due to the economic impact after COVID-19 pandemic and after the internal conflict, internal political conflict, internal armed conflicts, many periodicals like journal, newspapers, and magazines are stopped. And before, in 2014, so far I remember, there are more than 100 number of periodicals like newspaper, including newspaper, journal, and magazine, and monthly issue, weekly issue. But now, present condition in Myanmar, there is only 2 private-owned daily newspaper and 5 state-owned newspapers. Mostly, they are propaganda of the government issues. And then only not more than periodicals like a weekly issue and a monthly magazine are only not more than 10 numbers. And most of them are only focused on the celebrity, focused on the sports, focused on the entertainment. They are less, they are not much informed about the public health issue and other health issue. There is a very big problem. And number 2 is we have only a few number of health journalists. I mean scientific journalists, including health journalists. They are not well trained about the journalism. Though journalism in general, okay, but they are not too qualified to report scientific journalism and scientific news and health news, and they need training for the scientific journalism. And then there are some audiences are also less interested in like these issues. Frankly say, TB is an old disease, old health problem. They don't interest to read about this news if it is written very simply and very plainly, except the victims of TB and their relatives. So we need to change our presentation forms into interestingly written like stories, maybe stories or other forms of the media. Broadcasting is a little bit more strong points in Myanmar. There are many TV channels, both private and state-owned channels, more than 10, and also the other social media like Facebook, Instagram, and Twitter, etc. There are many social media platforms user in Myanmar. That is about in my study 18.5 million user for media platforms, and also the mobile phone user percentage is 27% of the whole population. Another challenge is ethnic language. Although 54 million population of Myanmar, about 60%, that is 33 million is Myanmar, that is Burmese, and the rest 40% is ethnic groups. There are 135 ethnic groups already, and they are using more than 100 languages. So very diversity in language. So in our periodicals and in newspaper, there are only a few supplementary print in the newspaper once a week or 2 weeks with alternate choice of the language, maybe Shan this time, the next time Chen, the next time Kachin, etc. A very limited use of the ethnic language. That is also a challenge. And then when we are talking about the media, we need more language to be in the form of printing or in the form of broadcasting, maybe in radio group programs or in TV channels. And these are the challenges we are facing in Myanmar. Yeah.
Okay.
Thank you.
Thank you very much. In fact, that was my second question. You brought it up, so we will club it with the first one only. So Kalpana, again, I'm repeating, what are some of the guiding points you keep in mind while reporting on TB? And in your country or local context, do you face any challenges or do media actors face any challenges while reporting on TB?
Yes, thank you, Sobhaji. Thank you so much for this wonderful opportunity. Thank you, organizer. Especially thank you, Sumit sir, and all the organizers team. Talking about your question, yes, media is the voice of voiceless people, and it's supposed to be a watchdog of the society. When we talk about the media, we media persons face so many challenges when reporting the tuberculosis because it has still a huge stigma. And we have so many myths and misconceptions regarding tuberculosis. So as a media person, we faced so many problems like this. Number one problem is jargons, technical words, such as TB involves DRTB, drug resistance, treatment regimen. So many these types of words are there, which we have to simplify it. But how to simplify? If we don't have training, if we don't have orientation, and we don't have so much knowledge regarding tuberculosis and its treatment process, so we are not gods. We are learning and we are writing for the people and for the laymen. So my big request to the organizers here, please let us know more knowledge and let's organize the orientation for the journalist so that they can write in simple way for the laymen and make them understand. And another thing is, yes, regarding your question, what kind of guidelines you follow? Yes, of course, journalism's basic principle is ABC, accuracy, balance, and credibility. So we follow this principle while reporting tuberculosis and other reporting also, we follow the ABC principle. But sometimes we while we are reporting tuberculosis, sometimes it may be misleading headlines, as earlier Sobha Madam said, sometimes misguide the people to give the information because of the unknowing the jargons and technical words. So that is one of the challenge. And another challenge is stigma. In tuberculosis, there is, talking about my country, there is very much stigma. Nobody wants to open up. And we have only one dedicated tuberculosis hospital in my country. Nobody wants to go for reporting at that hospital because journalist friends suppose that when they go to that hospital, TB hospital, they may be infected by tuberculosis. So this is the scenario. And I want to add one experience. I have a friend, Ayurveda doctor friend, and she had tuberculosis. Now she has recovered. I asked her to do a story of her success story, but she denied. She said, please don't disclose my story. So this is the scenario still in my country, maybe in India also, or other friends' country also. So this is our challenge, and we need more knowledge, more information, more orientation, and more priority to the media friends. So I'll stop here. If there is any, I'll add. Thank you.
Thank you. And you mentioned that your friend she did not want. I think, yes, that is also one of the basic principles, that we need the consent from the person, and ask him or her if, without revealing identity in any way, can we share it with others, that just to give, as you're saying, show it in a positive light, that yes, you can overcome it. That is just one suggestion, but yes, definitely you have to keep that issue, that consent is very important.
Yeah.
Yes, Vidya.
Thank you. Giving the same challenges and guidelines followed by the two previous speakers, it would be a re-emphasis of the same points. How do you balance accuracy with simplicity? How do you make your report? How can you, as we were taught in journalism school, you write for your grandmother, but at the same time, how do you write with accuracy, with simplicity, without alarming people? How do you protect confidentiality? And with news cycles shortening and becoming digital, and you're always chasing the next deadline, and your person on the desk will not understand the complexity of, having a 10-word accurate headline rather than having a 4-word catchy headline, so that it's picked up and it gets, more sticky eyes. So those are the challenges of a digital newsroom that TB faces. It has to compete with a lot of other news, with the other news of the day. One other point which I totally agree with is that training of journalists and training of the new crop of journalists also to be good health reporters, because the health beat, everybody became a health reporter during COVID, but none of them were trained, and which is why the infodemic, I think, killed a lot of lives, as much as the virus did. So how do we prevent that? Capacity building. Also, the challenge is that having trusted sources of information where we can go and verify facts, trusted, unbiased sources, which COVID has given us for vaccines, etc., etc. So the WHO verifies certain sources for good information sources on vaccines. Perhaps we need the same kind of ecosystem to be created for TB. And yes, as we've been hearing, I've only been hearing the sessions from today morning onwards. So what strikes me is that the learnings are similar across countries, both on the donor side, on the diagnostic side, on the policymaker side, and now from the journalist side and the media side. So with similar challenges and similar problems, probably there could be similar solutions as well. So with that, I'll hand over. I have two colleagues in the audience as well from India, and I'm hoping that they can add their points to it. Vikas and Shardul. And
We'll open it later.
Yeah, we'll open it later. Also, from a gender perspective, health is considered a very soft beat. So women are put onto this beat, but then health as a subject sometimes gets sidelined. During COVID, we saw a lot of health stories, obviously, but that's again receding. So how do journalists keep health and TB as part of health, as part of the news cycle, without sensationalizing it? So that is a challenge.
Yes, thank you, Viveka. And you were mentioning about the source of correct information. I think there are very many renowned journals where you get the latest studies published. Even the WHO website will give us. The thing is that we need to look for them. And yes, not write, and also not write half-baked language. And as you said, catchy title. And that catchy title is very often sensational, to create sensation. And when you, I think that was discussed in the morning also, when you read the article, and many people will not go perhaps beyond the first paragraph. So don't give false hopes and don't give wrong information as well. I think that is very, very important. And we'll talk a little more about the gender aspect which you have brought, and also that health is considered to be a soft beat. Fortunately, we are making a lot of strides, and we have many women in that field. And although it's a common complaint that the editorial post and the top posts are still very occupied by men. Apologies to the two who are there. So we thought of having an actual panel here and not just a manel. So we were extra careful of that. But that is slowly breaking. And that brings to point another thing, Viveka, that health, politics is supposed to be perhaps the best beat. But you cannot divest politics from health. Politics is the ultimate determinant of health. So that is important. And perhaps there should be more convergence between the different beats of which the journalists follow. That also has to be taken care of. And with more female power at the top, perhaps that change can be brought about. Thank you. Over to you, Zarina.
Thank you. Thank you. So I'm from Zambia in Southern Africa. So the media in Zambia is heavily regulated, whether it's private or government. Of course, government media dominates. There's a code of conduct. Everyone falls under the Independent Broadcasting Authority or a print media authority, where ethics, guidelines, and reporting is regulated. But that's not to say that everybody or every media adheres to those regulations. Most often than not, they do not. So you find sometimes content is skewed, it's inflammatory, it's incorrect, and in a few cases, it's sponsored. So we have similar problems with the media in Zambia. Even though there is some kind of regulation. In terms of health reporting, true, it was considered a soft beat until COVID hit. Because COVID was so political, we had political journalists trying to write health stories because they wanted to get onto the COVID bandwagon. So then, since then, we've seen a huge interest in health reporting because COVID seemed to be, it seemed to be a sexy beat. It seemed to be high profile. So we've had an influx of people, trying to write health, which hasn't helped in the long run because, of course, they don't understand the nuances. They get information wrong. So we've had to grapple with that kind of reporting. However, I coordinate a media science cafe where I bring journalists with scientists and researchers and industry folks such as yourselves here. And we hold a cafe. This is an informal discussion where the journalists and the specialists meet and they discuss a particular topic, for example, if it's HIV or if it's COVID or vaccines. And we also have a civil society representative. And from those cafes, the journalists go on and write either stories from the cafes or stories as a result of the cafes. So they go out and do their own reporting. And of course, we mentor them. So we've managed in some ways to take a hold of the quality of health news going out. But, these are 10, 20 journalists. And attrition rate in the media industry in Zambia is quite high. And we have the unfortunate situation where the head of state, carves out posts for journalists in the diplomatic missions. So you will have trained a journalist for, 6-12 weeks to write on TB or an aspect of TB, and then suddenly he's gone to Tokyo. So we keep having to train, but that is one way in which we try to keep the content, the health content, clean and safe. We do not have a huge issue of sources because our sources come from the industry. So far, we've been doing this for 3 years. So far, we've not had any libel suits. We've not had any complaints from researchers or doctors that we've misinformed them. What we do have a problem with is getting scientists and researchers to come to the table to talk with journalists. There is tension there. They are distrustful. And because the journalists sometimes oversimplify issues or terms, which the scientists don't quite understand or don't agree with, there's always a tug between the two. And slowly we try with engagement, we try to get over that hurdle of the distrust between the two sides. So that is one. Secondly, we do engage editors of the newspapers, of the of heads of media. We have engagements with them to enable them understand the importance of health stories so that they give it space, because oftentimes we have to, we have to compete with advertisers or big farmers who take up a lot of space in the media. So your stories get pushed down and they don't have the effect that you have. So we engage editors as well on a regular basis so that they understand when they get a health story that it's important and they should, they should pay attention. We also do mentoring in the newsrooms for health writers. So we try to keep this chain moving so that there's never a time when media can say that they don't have health stories to publish or to air. The media itself is not geared. It's a very political, so it's not geared to stories that are not political. So it's a competition. You always have to be the best. You always have to have the better story. You always have to have the more audience engagement. So we try as much as possible to make the stories interesting. And what we found is that if you talk about people, if you make it people or community centered, usually we have lots of hits, we have likes, our stories go a long way. And also we try to keep the stories alive. For example, with TB, it's been particularly difficult for us. I came here and I found out that Zambia had some validation and, I was supposed to hear this at home, but we don't get information from the people that we should, the policymakers or the stakeholders. So there's a lot of information out there, a lot of interesting information out there, but it's not coming forward to us. So digging for it becomes, a little bit difficult. And if you've got like 10 other things to do, you lose out on your TB story. So those are some of the challenges, but I hope I've also talked about some of the solutions. Thank you. Yes. No, just switch it on, I think.
Thank you. So I'll be very brief. So to your first question about what should be the priority of when writing tuberculosis. So I think 3 things, which is accuracy, sensitivity, and raising awareness, which is about prevention, treatment, and stigma reduction. So when talking about tuberculosis writing. And regarding the challenges, I would say, first of all, then I will take little time because when you work on with any media in any country, I think first you should understand, the media landscape, the country context. This is very relevant because
you know, every country has its own political, economic, and social dynamics, and media is I mean, it's just interlinked. You cannot ignore or you cannot separate it. So, for example, if I talk about Bangladesh, so Bangladesh, you know, we are a densely populated country, and it's one of the largest countries when it comes to population. But in land-wise, we are a small area. We are about 200 million population, and our economy, like we are a relatively new country because we were born in 1971, and thanks to India for its support also. So after the independence, if you I mean, hear the speeches of our founding father Bangabandhu, and he was telling people, asking people to cultivate rice because people did not have rice to eat. They could not eat, I mean, thrice a day. But if you see in the last 10, 15 years, our economy is now in such a way that our prime minister inviting the world to come here, you invest here, you make your cars, you make your industry, do everything, and then you export to other countries also. So it's just changed. So this whole economic perspective, and then comes the politics. Politics is a democracy, so a lot of noise, you know, politics, election, and before the election, you say Bangladesh get the international headlines also. So it's a very challenging thing. So I'll not elaborate. I'm just giving the highlights because in these circumstances, when from a media point of view, definitely these things will take the, I mean, front page or the headline, certainly. Then why not TV? Because I think the first challenge I will say in such a way that limited resource. That what does it mean? Limited resource, despite the fact that, number one, Bangladesh is a high burden country when it comes to tuberculosis. Number two, Bangladesh government, they have a separate program for tuberculosis. Number three, world's largest NGO work for tuberculosis in Bangladesh. And still we media calling it limited resources. Then what's the problem? It's a serious problem. And there's nobody looked into it. So that means that the government, the NGO who are working on that, they are reluctant to do that, or they don't care about that. Maybe they interact with media when they want to exhaust their donors' money. And only then they organize some seminars, workshops, and then they invite the media. Because I am talking about that because you just scan the newspapers, our national newspapers, you will not find tuberculosis stories in newspapers, even in a month, except those seminars, workshops. Then why? Because we are a high burden country. I said that, high burden country, we have government programs, the world's largest NGO is working there, is still no tuberculosis report. So we are talking about stigma. Stigma is also there, but what is that stigma and how deep it is? There is no study about it. In here, we are talking about like people living with tuberculosis, TB India, TB people Zimbabwe. So where is TB people Bangladesh? Where are they? And nobody is talking about it as if there is no TB in Bangladesh. So it's a challenge, limited resource, because without that, because I initially, why I trying to say that? Because the political context, economic context, social other context, that will always take the media attention. So when this type of issue, it should come from the other side also, like from this government or the NGOs, they will come up with a lot of ideas, new things. Because I write many of the stories because I get the idea from my international friends. They suggest me, they insist me write something, and then I write that. It's not coming from my own local people, right? And second thing is I also and access, and that also and related. That is also related, which is the access to experts also, because when you people, I mean, the government programs or the NGOs, they don't have the media priority. Then certainly you will not find so many experts or relevant people when you want to, I mean, write stories. For example, this molecular testing or this scaling up this equipment, Truant or other things. So what is going on? You will not find an independent expert in Dhaka who will talk about that. Even the childhood tuberculosis. One, two, like pediatrician, they will talk. So that pediatrician, like one journalist has to know that who is that exact pediatrician or doctor who can talk about these issues. So these are the certain challenges, and I think everything is covered. I just trying to say for time, saving time, I'm just a specific issue. And always misinformation is a big challenge now, you know, in the social media. when Bangladesh, again, I say it's in the last 10, 15 years, our internet users rate is rapidly grew. And everybody is using Facebook. And because of the politics, it's a heavily polarized society for the democracy or politics. So people always tend to give misinformation. That's the first job is today, to create panic, to sensitize the thing. But which is in case of reporting TB, which is very bad for the, for the cause, for the person who is living with TB or for the disease. So I'll stop for this question. I'll stop here and next I will.
Okay, so you think that there is less of community participation there and less community-based organizations in Bangladesh?
Exactly. And in the morning panel, when you ask the question to the government official here, and he still could not relate that thing because there was not, we don't have such strong, community, like people who live with TB or the TB survivors or who already recovered from TB. That kind of community doesn't exist in a way in Bangladesh. Maybe they exist, we don't know. Maybe I am not, because they are not coming in front. So that's why we cannot, write, you will not find so many case studies even. So once upon a time when the HIV was a big issue, and then there was some community group who were living with HIV that time. But that group is over the years, maybe some, and another thing happened in Bangladesh over the years, as a journalist, what I have followed that NGOs mostly, they are dependent on donors. So donors, they change their focus with the donors' money. So that's the problem. That's why 30 years back, population was a big point of discussion in Bangladesh. But after the ICPD, the focus changes and the population is not a topic for discussion from the NGO point of view. So that's a problem. And from the media, that what I again said, that because of our big focus is elsewhere, politics, economics, or the other things. So when I don't get any, pressure or any suggestions or any new insights from my country or or experts or who work on that, then you don't get the new attention, on any topic.
But TB continues to be a problem. It was a problem then, and it is still a problem. So that is, it should not be, but it remains. So any special issues, Dr. will start with you, which you think media should focus more upon while reporting on TB, keeping in mind that we have to achieve the end TB agenda. And its agenda means having targets is good, that you are aiming, and all our countries have, or country heads have signed, accepted that target of ending TB by 2030. But then it should not remain to just sloganeering and just slogans. But so you think there are any special issues which need to be focused more upon?
Yeah. When we enhance our activity, the way to the NTB journey, in my country context, we need more actions. First of all, it may be to expand the media outlets. Very less media outlets in our country, not only printing but also the broadcasting media. We must expand as far as and TV channels and radio programs should be more focused, and also social platform should be more focused, because in this time most of people would not like to read newspaper or books. If they see the TV channel or they listen to the radio program, it is very easily educate and give information to them about the NTB. And also, previously, I also mentioned about the scientific journalists, but they are less interested in to write about the health issue like the TB, especially NTB. Most of scientific journalists even don't know about what's NTB. They don't know. They just know about the non-NCD disease, they know, they interview with the clinicians, and they describe about the disease, how to prevent, how to treat, and how to diagnose, etc. They all focus only on hypertension and diabetes or something, cardiovascular disease, etc. They don't not much interest in NTB. Yeah. Well, they don't know the knowledge of that inside of the NTB. We must persuade them to write about this, and this is why I want to suggest is, especially focusing on the NTB, we should make a workshop for journalists focus on the NTB, not on the whole long story, but also but only focus on the NTB. The presentation forms should be changed. I also previously said that the interesting stories, they need interesting story. The story must be persuasive to the audience as to read or to listen or to see in TV. So we must change the forms of presentation. It may be more on edutainment. That means not only educating about the TV and NTB, but also the entertainment. We must mix them with like dances or music, and I think in this digital creators are very crucial role to create like these stories, and most of people can see that using their mobile, and they see in Facebook or any social media platform. Also, some program like Quicks about the NTB. We will make a quick program. They give in the multiple choice questions and let them answer the question. Those who wins the Quicks will be rewarded by some phone bill or some small token or something like that, so that they can be attractive and they will interest to know and to read and to listen and to see about the NTB. And also training for journalists to write about the NTB is to meet or to interview regular basis with the something like TB project manager or authority concerns or something maybe from Ministry of Health or other private sector. They need to interview regular basis, and they will give information. They will talk them to focus which problem must be prioritized. And for these works, we also need the sponsorship. So we must find sponsorship for this activity. And also, there is forming a network with NTB, maybe locally or maybe internationally, and we exchange and our experience, and maybe virtually or in person. They will be very active, so that the journalists may be active, and they will write, they produce news stories with the about the NTB. And then this is a very simple way that there is to produce IEC materials about the NTB, because in our outreach area, they can't give time to read or to listen or to see if the poster or billboard or something like that. We must also use the local languages and about the shop TV, NTB, and etc. But make a IC material and it is to distribute to the grassroots level. And then these are so far I could or imagine to extend to more active participation of the health journalists.
Thank you. I'm sure you are a part of the Find All TB to End All TB group, and we are trying our bit to post the latest TB news and latest studies. Which there is a WhatsApp group there, which we are posting every day on that.
Yeah.
And I hope more people join it. Where if you think there is a lack of proper or information, articles, yes, are there. But then again, whatever is there, we have to analyze it. I think it is important not just to regurgitate or amplify what is told to us, or the messages given, but that is the role of the media to analyze before reporting. I think that is important. Yes, Kalpana, any issues you think which should focus, which media should focus more upon?
Yes, Sobhaji, I'll keep in very short in points because my friend elaborated so many things. To end TB, number one is I think there should be political commitment. If there is no political commitment in high level, it is impossible to end TB, in my opinion. And number two is to end TB, according to our target, investments should be increased. If there is no more investment, it is impossible. And another is media is bridge between TB people, investor, and the government. So government also can use media to achieve the TB target, so that media can do the campaign, media can do the awareness program regularly, so that people can be aware, and it will be easy for the treatment procedure too. So this is the story, and we can do a more and more successful story for TB survivors, so that treatment should be possible and easy also. So this is my points.
Hello, I think, I'm repeating all the points, but the emphasis needs to be on the impact that TB is going to have on the future generation. Because we've been seeing in the last couple of days, at least in India, there's a lot of concern about lowering fertility rates and replacement rates. It's gone this, and the writing is on the wall, because if you don't have a population, then you don't have a voice. And if some part of your population is going to, or your future population is going to be debilitated by TB, I mean, you can, drugs might, make you a patient for life and you can treat TB, but obviously there's going to be loss of manpower, loss of, the focused and, you lose your place in the STEM world, etc., etc. So TB can be a huge debilitator. That way you're going to lose your voice. You're going to lose the next generation. I think we need to create or at least sensitize people to the fact that TB can be that difference between a nation being up there and not being in that, we've seen so many nations like the UK, etc., slipping in that world index of GDP. And as we are seeing, populations across the world going silver and going gray, and, I think that the next, differentiator is going to be, how latent TB is, is there, and we need to discover that and see how it's going to flare up. At the risk of sounding sensational, possibly we need to work on TB in COVID mode. Track, trace, test, and treat, and then track and trace again. Because I think only that will really kind of, make a difference and move the needle really. Unfortunately, unless you use those shock tactics, things will not shake and things will not change. But how do we do it? How do we, do it in a more sensitive manner and things like that? But otherwise, I mean, we've normalized it, Okay, we all have latent TB, so what? I think we need to, emphasize it's a big deal and why it's a big deal and why it's a big deal not to us, not to our generation, but to the next generation.
And yes, rightly so, and it's not just the future, it's the present which is already being devastated. And the economic cost of TB, as we all know, is very, very high. And means that studies have said that $1 spent on TB makes you give a worth of $40. You are saving $40 by spending. So it makes a lot of economic sense, other than the health sense, of course, saving lives. That should be at the topmost of our minds. Yes, Zarina.
Yeah, sure. So yes, definitely TB should be go into COVID mode where we saw a lot of traction. There was so much political will, there was so much resources thrown at it. So, ideally TB should have the same gravitas. I agree with the other speakers. There's lots of challenges and there's lots of things that we should be doing, but I'll stick to what is, probably in our control. When I talk about our control, the media in Zambia, because it's very few resources going around. There's a total lack of political will. We don't hear about, just like what you mentioned, very rarely do you see a TB story. But what media can do, what our media can do, is use what's available to bring the TB story to the fore. And to do that, oh, by the way, I've taken note of every doctor, scientist here. You're on my database, so expect emails from me or my reporters. So what we can do, which is less cost effective and probably the little resource that we have, is to widen our networks. For example, like I said, I've created a database of researchers here who we can contact. For example, TrueNet, that is going to be used in Zambia. What does it mean? Who's going to use it? So there's a story there already, and it doesn't have to be just the Zambian doctors or experts talking. We could extrapolate that story to make it Africa-centric or Southern Africa-centric, and using a lot of community perspectives. So it's writing not hardcore stories, but narratives. For example, you take one person that has survived TB or is undergoing treatment, or has been a carer, and use those stories, because those stories always tend to work where you have a personal narrative. And also we do try with our journalists to make the stories as base, like we don't use jargon, we don't use medical terms. Sometimes we use colloquialism, which is understood in communities. And other times we use direct translations so that it's understood, especially for radio, so that it's understood by many. And we found that to work too. Where we have an issue, I suppose, is the stigma, which is everywhere, I suppose, and discrimination. People with TB, it takes a long time for them to reintegrate into communities. And that is something that, we could continue writing about, as we did with HIV and COVID. And hopefully, it'll permeate, the message will permeate to society that, they shouldn't discriminate against TB, and it's not a poor people's disease. And, it could happen to anyone. And also, when politicians tend to react when they are pushed, unfortunately. And I think that's across the board. So when media, for example, decides to push for something, like, for example, to push for more resources to go into reagents or care, or, just things that go along with TB treatment, they tend to respond. So I think for journalists there is we've got journalists against HIV, we've got different sector journalists. So perhaps we could use those pressure groups to pressure government into providing more resources for TB programs, even for TB training for journalists, how to report accurately on TB. And one of the things that we always do is have training sessions on misinformation and disinformation. That is very important because one wrong sentence in a TB story will just send a wrong message. And it always, when you're writing politics, you can get away with misquoting a politician. It will just be oops. But when you write a health story and you get something wrong, it has a life-threatening impact on the community. So we try as much as possible to be accurate, totally accurate. And in doing this, we rely a lot on experts and doctors to either confirm a preprint or to confirm sources or to confirm a fact. So, yeah.
What is the question?
What, any special issues which media should focus on, should focus on more while reporting on TB?
On tuberculosis?
No. Any special issue? Or...
Especially at this moment, I think since we have SDG, I mean, in next 7 years it will end, and there are some specific targets which is very, I mean, focused for every country. SDG was unique, unlike the MDGs, because when you, and you also said that when you, I mean, talk about TB, it's not that you will work only on TB. You have to work on hunger, poverty, malnutrition, everything. So I think that's an opportunity, and we should, I mean, look into that, use that. And for journalists, I think education and training. For example, every journalist has a kind of, I mean, knowledge of writing a story. I mean, that's the journalistic knowledge, how to find a story, how to write a story. But writing a particular topic, for example, new things coming up every day in the world, right? Climate change, even like the 2 decades or even 2 decades back, it was not such an issue to write about. But now it's what does it mean? The journalists are even writing news every day, even 2 decades back. But when the climate change came, they were trained up with the climate change issues. And now we are writing thousands of stories. So that's the key. I mean, when the new things come, which is technical, mostly scientific issues, so you have to provide the training and education. So in this regard, I thank Molbio, because the private sector, because what I said in my previous, intervention, that what we said, that NGOs intervention was not, sustainable, because NGO changes their tone with the money. So private sector is simple. They are doing business. So they invest for a sustainable cause for a long time. So I think, and they have the CSR kind of things. We have a presentation on CSR. So in Bangladesh also there is CSR, and they must spend some money. It's a rules by the central bank in everywhere. So that CSR, I think, should, so part of it should go for journalist training and education. So Molbio, and I think certainly they will continue to do that. So that will be helpful for, and that's why I am appreciating them. So, and so that they continue. So it's useful for their business also. So I think that's, and partnership. I think education, training, and partnership are also important. And that's what the government entity can do. Because in government in Bangladesh also, we said, what I said, that occasionally they tie up with the newspapers, like specific on day, like Tuberculosis Day or Malaria Day or any other certain days, and they tie up with the newspapers. They publish special supplements, and there are some, that what I said, the seminar, workshops, and that partnership works for the time being. But what happens that they don't follow it up. So if we just, if they can, they can set a kind of mechanism, I think that mechanism will come up automatically if you focus on that. I think they should focus on media, that, okay, I have to, in my program, I have these components. Another component will be media. I will always be in media. But the problem is that transparency matters. That's why they avoid the media. And that transparency matters. not only in government, that also matters within the NGO also. So that's why, this is all thing it's a chain, it's a cycle, you know. When I am talking, I was just talking, memorizing one after another, and at the end of the day, I say all are linked. It's heavily linked. So that's why there is no like one simple sentence to complete the solution or other things. I think.
All right. Now last round, starting from your end, just one action, which not more than one action you mentioned, which can be done to enhance active media participation to help us on this path of ending TB. Any one thing which you think is important?
One point, I think partnership.
Okay.
Under the partnership, we can do everything.
Partnerships with whom?
A partnership with media, like between those who work with tuberculosis. It can be the people who live with tuberculosis or who survive TB, or the government entity or the private sector, like the Molbio who who will remain in this field because of his investment. They're investing heavily, so they will not go away. So if we have a kind of partnership, then the issue will survive. You know, issue will always be there. And TB, another thing is that it's a decade-old disease. So over the years, you know, what happened during the pandemic time, pandemic is still somehow is there. It's not that the virus is completely eliminated. Virus is there, but still, you know, now the lifestyle or other things, people are not following that kind of rules. So, you know, sometimes it, loses attention, you know, over the time. So to keep the attention, to put it in focus, I think this partnership will work.
Zarina.
Yeah, I adopt those words as my own. I think partnerships will work, and also training for the journalists. I think that is important because TB has been around for a long time, and yet I think we forget about it every so often. So I think thematic training on TB would be good.
Okay, Viveka.
Yeah, I would say, third, that training, because all these diseases are ancient diseases, be it TB, polio, leprosy, and we took the eye off the ball for leprosy, and there's an insurge of incidents in TB, at least in India. So don't take the ball off, keep it a hot topic. And for that, you need training, and not just of this generation of journalists, but the next generation of journalists. So I would say media training also at journalism schools. And I say that because I teach at a journalism school. I think all journalists do take guest lectures at their alumni, etc., etc. So we start early, and we get students of media used to reporting on a technical subject. So then you make it a habit at that. The earlier you start, the better results you will have. Transparency is a huge issue. So we need to also tell them that, trust, verify before you trust, and, keep verifying your source from where you're getting it from. And yes, you can have a partnership, but, also there should be total transparency in that partnership, because with NGOs, there's always an imbalance of power also, so you need to be alive to that kind of bias as well.
As Nurul said, I agree with him. As a partnership part, we can add more fellowship and scholarship programs for journalists so that they can motivate to do more successful stories. So I will add that.
We do have such programs in India, at least there are few scholarships. Yes, just one action, Dr.
Yeah. For me, I think we health journalists need to interview with like TV project manager or something, officer from Ministry of Health, focusing on the NTV to SDG 2030. We must update the news, the progress, and maybe monthly or maybe quarterly, and we must describe in our media about this.
Thank you. Any comments, suggestions from the audience, or any clarifications? Anything which they want media to do more or focus more upon?
Thank you for the presenters, and maybe it's the last day and I might have the liberty of being controversial. And my question or comments are not to you, but to all of us here. You know, having talked to different people about TB, one message that usually comes up is that we understand TB might be a disease of poverty, but even the people who work in TB seem to have accepted that. We are very quick to say we should learn from HIV. We have said that for many years. Now we are now saying, let's learn from COVID. And yet we continue doing the same things. The other one, I think maybe from the journalist point of view, it's our messages when we talk of stigma. Quite often in our countries, we hear about TB on the 24th of March. When we, the same people, wear T-shirts, shout in the streets, stop TB, end TB, fight TB, who are we talking to? If it's really an issue, should we not try in our countries, maybe also through the journalists, that even if it's every month, we take a different angle and talk about TB? There are good things that have happened. However, quite often our headlines, there are more deadlier strains of TB. Every hour, so many people die of TB. So those who are suffering, when you read such a message that so many people are dying, might also be contributing to the stigma. And I think for us also as journalists, maybe we should ask that don't only talk to the ministries of health. Ministries of finances should be asked, what are you doing about TB? Ministries of housing, because quite often as we working in TB, as much as quite often we're already very protective. We have new diagnostics, we have this, but what are these other ministries doing to talk about poverty? You know, another thing is also as specialists. This is, I think, one of the few diseases that as clinicians, we're very comfortable or not even embarrassed to start people on treatment without a diagnosis. I don't think that we had yesterday, I think Saho mentioned something that like Zimbabwe, at least 100% of the people who had been treated had had a diagnosis. How many of us here would say that? So if we say 70% or whatever percentage of the people who were treated for TB did not have a correct diagnosis, how would you feel to be treated for a disease that you might not have or might not be treated appropriately? Again, it's related to tuberculosis. And the last one, unfortunately, we are very quick at setting targets. Every 5 years at global level, there's a new target. There are UN high-level meetings with new targets. When do we ever go back? Or maybe the journalists ask that here you are coming up with another new target. Why did you not reach the last one? And what is it that you are going to do different? I think the investigative journalism might not be the right way, but also hearing the stories for the patients, not only bad ones, do also help in highlighting some of the challenges related to tuberculosis. I think we still have a long way to go, but maybe my message to you today is that you can talk to us, but please try to reach out to other important ministries in our countries to account and show their commitment to tuberculosis. Thank you.
Thank you, ma'am, for also compliments to the delegates from Zimbabwe for 100% molecular diagnosis. This is really important. Thanks for reminding that. And we really wish that the 40% of the missed cases in Zimbabwe are also able, you are able to reach them and offer them upfront molecular diagnostics.
Hi. Again, I am repeating some of my comments, echoing in the morning session I shared, because this is the right platform to share. The challenges regarding the, now the funding issue, funding transitions. Now the donor is preparing the country for the sustainability and transition readiness, and gradually there is a redundancy of the funding issues. At the same time, like Bangladesh, like country, when we are preparing for the middle income country because of the global warming, country is in now big threat of the internal economic, okay, and then doing so many cost efficiency planning. So when there was in the beginning, last 20 years, there was a big investment in the ACSM and the awareness program. Now every program has been shut down. Like there was a program, journalist orientation, then the journalist fellowship. In such program, and World TV, even we cannot do any kind of publication in the paper. There is no funding, and also we are in the funding scarcity within our government system as well. So in such situation, that is really challenging. And we are also recommending your recommendation that, but at the same time, there is a new issues coming. There's the multi-sectoral accountability framework. So we have developed our assessment, SOP development, but now when we look for the implementation of the strategic operational plan, we need the actors. So there is no funding. So I asked to my donor, then there is a CRG action plan. In this grant, there is no fund, but government strategic plan is not ready with that NTB strategy and goal. So that kind of activities is not in the GOB plan as well. Then multi-sectoral accountability framework, if we plan to organize a meeting with different actors like Ministry of Planning, Finance, etc., and in the other corporate social, private sector, everything need money, but money is not there. That's why we are encouraging now that CSR, corporate social responsibility. So my question here for this, now our government, our program and donor now encouraging resource mobilization, you go for the resource mobilization. How on that context, actually, our journalists can contribute in the corporate social responsibility, because some of the journalist platform is also like Pran company, like so many big like company, Molbio is also in different countries. So how journalists can contribute proactively, because money is not there anymore. That's my questions to my journalist forum. Thank you. Anybody would like to answer?
No, basically, we didn't ask for money. So basically, it's all about the. No, understand. I'm joking. So basically, what I try to say that, a journalist is all about like connections. That is matter. And when you have connection, and if you continuously, give your message, what is happening. If you continuously keep us updated, and then I will when I find it interesting, I will write it. Because every journalist, their main intention end of the day, because this is the only profession in the world where there is no any office file or anything. Because in the morning, people can see what I do, my office can see what I'm doing. So it's a everyday job. It's a completely different profession, like your government job or other job. So that's why I always tend to, for example, sitting here, I am just exchanging WhatsApp message with the State Department, because the State Department made a statement about recently, Donald Lu visited Bangladesh and there was some controversy, and then I'm writing the story from here also. So it's our like nature, so we will do it. So you just keep us updated. You make a framework. It's not money. Nobody will ask you money for a news. That for sure, anywhere in the world. It's anywhere in the world. Maybe some promotional things, advertisements, other things. That's the thing, because you spend for advertisement. So you spend that for journalists also in the media outlets. But for news, that is for sure. I can guarantee it's across the world, not in Bangladesh, because I have traveled a lot and I led Journalists Association. So I can talk on behalf of the journalists so that nobody will ask for money for writing a story. Thank you.
So in such a way, you want to recognize you because your pain is so powerful, your voice is so powerful. So how we can recognize your contribution, that is our citizen responsibility. That's where we are encouraging for. Thank you.
And also just to add on, I get your point. So usually when people, NGOs, CSOs, even the governments, when they're compiling their national strategic planning or any plans that they have a very small component for media, for communication. It's usually at the back of the page, maybe 2 pages as an afterthought. And yet, at every stage of their plan, they need media. They need media when they launch, when there's a new innovation, or something is happening, but it's never, media is never invited to the table when plans are being made. Even our National AIDS Council, recently we had to push back when all they were calling was for donations. They were receiving donations of vehicles, they were receiving donations of drugs, and we said, look, we're not here to just write about donations. We want to know what's happening. What are your plans? What have you been doing? How are we with the UN goals and stuff like that? But because people don't consider media as a partner, a strategic partner, they tend to use it as an afterthought. And that's never a good idea because you'll get at the most 1 or 2 paragraphs at the back end of the page. And that doesn't bode well for a partnership. So I would encourage, when you're doing your strategic planning, have media sitting at the table, and they will tell you at each stage of the way, here, we can have a quarterly press briefing, or we could have a field visit, or something that raises the profile and keeps, the subject on the table.
No real points to add to that, because I think it's very similar to what we would like done in India as well, a seat at the table when policy is being made, and not just an afterthought. Thank you.
I think she has got her answer. Yes.
I would just like to add to your question. You are saying, how can media help to get money from the CSR activities? I think the role of media is to inform and motivate the public and community about their rights, about what is available, so that the demand comes from the community. And media can create that awareness and information, because it was discussed in the morning also, very often there is lack of information. People do not know. So that their media can play a very important role. And let the demand come from the public. Demand for upfront molecular diagnostic, upfront DST, demand for the treatment, the latest available treatments which work on that person. So those demands the demands can be amplified, and media can play an important role. Anybody else? You want to say something, please?
Yeah, just very quickly. That's a very important point which our honorable guest from the Bangladesh government have raised. Madam, it is never about money. I think it is only about an issue which has brought us all here, and it is the tuberculosis. It's a human right imperative. Otherwise, no, I totally get your point. But I think we need to, ma'am, please, just allow me to just finish this, ma'am. There's a line between public relation agency and those media you really want to engage, like Nurul, who has been consistently reporting on so many issues, like Kalpana, who has not only reported on tobacco control and tuberculosis, but also challenged tobacco industry when they were trying to do corporate social responsibility and donate money to a cancer hospital repeatedly. We got legal notices from companies, tobacco companies. So yeah. Yes. Right. Resources. Yes. Right.
Sit with the private sector for the multi-sectoral accountability, for the community rights and gender. We have to sit with the law enforcement agency for the empowerment, for the occupation, for the rights of the TB patient. But we cannot sit with that people. I did not mention about that. But we have that kind of new strategy in our strategic plan, but we did not money to channelize or no platform or vehicle is over there. That's why I'm requesting media is an opportunity how they can engage on that strategic development. Thank you.
Thank you, ma'am. Thank you. And we commit that, we are, if there are no budgetary allocations, when it comes to TB or really rights and health, we can facilitate online press conferences. And journalists who are willing to support, for instance, Nurul is right here. Nurul, I can bank on you, we believe. So I think that is really important. And so it's, again, I will repeat, even if there is no budgetary allocation, what about meeting rooms in the ministries? Can't we use those ministry rooms? When Nurul was the Secretary General of Dhaka Reporters Unity, he is evident that DRU meeting rooms were used for trainings of journalists on disability, on sexual health and rights, on including tuberculosis and others, without any budgetary allocation. Yes, ma'am. Yes, yes. So I just wanted to say, see, Mahatma Gandhi, who is a big inspiration for all of us, he used to say, it is not about money. It is about the cause. Once you begin working on the cause, money will follow. And I truly believe that we will find a solution, even if there is no budgetary allocation. Thank you.
Thank you. I think she was trying to say another point regarding the Bangladesh's graduation from the LDC to middle income country and the future of funding donors money. I think here comes the role of private sector that I previously said, and while thanking the Molbio, because the private sector will be the sustainable source, because they invest money for profit. It's very simple thing. And out of the profit, they spend for CSR or other things. So I think what you are doing with the, development partners before, you can try with the Molbio or other private sectors. You can sit with them, you can convince them. And look at the BRAC case in Bangladesh. BRAC, over the years, they changed their strategies, and BRAC is now more sustainable. They are generating money internally. Yeah, they have some enterprise or other things, and they are using that money. They are getting the donors' money also. And in Bangladesh also, in many sectors, yes, like government was heavily dependent on donors once upon a time. Now government take up those issues internally. Now government is funding, but because gradually donors' dependence is day by day is decreasing naturally, because our economy is going up. That what I said, that from 71 and now the 2024 is quite different. And last 15 years wise, it's a huge difference in Bangladesh infrastructure development or other developments. So certainly, I think the collaboration main next phase will be the public-private collaboration. That would be the key.
Yeah, thank you. And I will quickly give you another sterling example. At the World Social Forum in 2024 in February, the only session on tuberculosis was hosted by Kalpana's institution, Health TV Online Nepal. The only session on TB on World Social Forum. And we wanted space. What happened? She went to Dr. Prajwal Shresthaji. He is the head of the NTP in Nepal. And NTP Nepal Ministry of Health opened its auditorium. And the meeting was held inside the auditorium, a free-flowing dialogue on tuberculosis with engaging range of partners. So thanks a lot, Kalpana, for really stepping up. Not only engaging a lot of media people, but also all stakeholders and so many other people who are involved in social rights and social justice movements. Thank you. Without a penny, without a single penny budgetary allocation.
Thank you very much. Thank you to all the panelists and the good work they are doing, and the good work we will continue to do in whatever way we can. And I do hope that in my lifetime, I'm able to see that no investments need to be made in the field of TB. We are able to eliminate it. Thank you.
Thank you.
I have a very bad muscle pull just now. I won't be able to. No, you get it. I'm just not able to move my leg. Koi muscle pull ho gaya, it'll be fine, but right now it is difficult. I'll stand, just wait. A muscle pull is there.
Um, everybody, we're almost coming to the end of our MOH, the United Against TB sessions. I just want to take a few minutes to give the countries who had requested to say a few words, if they're still interested in coming and saying a few words about, from their end. I believe it was Sri Lanka. Anybody from the Sri Lanka team here? You wanted to share a few things? And I think the other request was from Malawi. Anybody from Malawi? They've gone out? Sri Lanka, would you like to say a few words before we go to the statement? Any other country? Bobby, you have the presentation?
I'll just. Yeah. Good afternoon, everyone. So thank you for the opportunity. So actually, by this time, I'm just like, just feeling like we are the odd man out here, the Sri Lanka, because we have a low case burden for TB. It's actually 62 per 100,000. So per year, we get only around 9,000 patients. So when I was talking with some of the colleagues here, they said, no, you don't have TB in Sri Lanka. So according to their country situations, it's not a big problem. So, but from the other side of it, for us, for our country, TB is a problem. It's the infectious disease reporting highest number of deaths. It might not be high according to y'all, but close to 800 deaths per year. And the thing that I see is now now this is the third day I have seen you are present, your country experiences and everything. And I have seen remarkable reduction in incidence and great progress towards ending TB. When we look at our country, in 2015, our baseline target for incidence was 65 per 100,000. Still, by 2022, it's 62. So we are stagnant. We are stagnant. And the funding agencies, they are more interested in high burden countries where there's high population, high investment. Sorry to say this, but that is the truth. And not that interested in countries like Sri Lanka, where there is low case burden. Yeah, there's the presentation, but it's okay, I'll just, yes. You can see here. Okay, thanks. Yeah, you can see here what I said. Now baseline 65, still by 2022, it's 62. Deaths actually 648 in 2015, it's increased almost 750 by 2021. And next slide, please. Yeah, this is actually, I'll skip. This is just the structure in Sri Lanka, bit different to other countries. TB control is mainly, actually only by the government sector. Drugs available only in the government sector. Case notification has to come to government sector, and then only drugs will be issued. And it's more of a vertical program. The decentralization is not that much. Next, please. Yeah, this is what I said, around 9,500 cases last year. Next, please. Yeah, this is according to WHO estimates, 62 per 100,000, but we are around 42 per 100,000. Next. Yeah, so the case detection is around 67%. Actually, during COVID times,
it went below 50% also. So according to our targets, we are missing a lot of cases. Still around 5,000, 6,000 cases we are missing each year. Next, please. And this is DRTB. Actually, our annual target is around 86 MDR-TB patients per year. But even from that, we have been detecting most of the years even lesser than 20 cases. So actually last year, we detected 28 cases. So next, please. Our targets might be less, but still out of that, we are not doing well. This treatment outcome, you can see our treatment success is going down naturally. It's 78 in 2022. Earlier it was around 84, but it has gone down. And you can see our death rate is going up. It's 9% almost. 1 in 10 TB patients die in Sri Lanka. So for us, it's a huge risk. Next, please. Yeah, so this is actually something good for us. TPT, you can see under 5 TPT coverage, we are doing well, probably because anyway our numbers are small. Our treatment under 5-year household TPT on preventive therapy for 2023, almost 89%. I think in the region, we are doing very well. Next, please. Again, for household contacts, almost 18%. Next. Yes. Yeah, bacteriologically confirmed, because this is more related to diagnosis. I included these slides. You can see out of how the blue line is bacteriologically confirmed cases, it's going up a bit. But still, even by last year, only around 50% we have achieved universal DST. So still there's a lot of room for improvement in Sri Lanka. Next, please. Yes, this also, we are improving for diagnosis. In Sri Lanka also, we are mainly still doing sputum microscopy, but we are improving. You can see by 2023, around 19% were diagnosed with gene expert, because still we don't use TrueNet in government sector. Next, please. Yeah, this I think we can just mention. Yes, there is multi-sectoral, multidisciplinary platforms. We try to get involvement of other stakeholders. You can see a lot of stakeholders, they are there, but we need their active participation. So it's not only that funding agencies at international level are not that much keen, even in our country, the political commitment, we've been talking about that, even from ministerial level, we need more interest. Even to secure money for anti-TB drugs, we've been fighting a lot. And actually WHO Global Fund, those agencies have been helping us, but still the response we get from our government side is not that much. And even for the social protection, now TB is not only from health sector, there should be multi-sectoral engagement and social protection. So we see that especially with the financial crisis in Sri Lanka, lack of support, especially for diseases like TB. So the allowance, around 5,000 LKR, it's actually almost nothing. But still, that is not provided uniformly to TB patients. Next. Next, please. Yes. So this is one thing, actually, good thing, a peer group formation. Earlier today, we were talking about post-TB follow-up, but this actually peer groups we have in Sri Lanka for diagnosed TB patients while on treatment, especially in estates. This was created about 1-2 years back. So during that period, this is to ensure their compliance, and also we get them involved in active case finding and patient referrals, especially in estate sector. And of course, our specialized vertical program stops at district level, district chest clinics. After that, of course, it's integrated into the normal service system, health system in the country. Even though it's not optimized, it is still there at PMCU level and also other hospitals. But yes, prison, we say they're high risk and all that. But we are doing screening, but it's not optimal because of lack of resources. Next, please. Yes. So as I said, still in the government sector, it's expert MTB reef. Up to now, we have 32 machines. One is for XTR, and we are waiting 3 8-module machines. And this is actually some of the progress that we see. BPAL-M regimen we are using. Then for TPT, we've been using 6H, but we are going to move to 3HP. And also we got TIGRA facility now. And SciTB planned within this year. I'll explain it in the next slide, please. Next slide. Yeah, some of the research. So this, because Sri Lanka is a low incidence country, we can't go for community incidence. So this TB inventory study is suggested for us during the international reviews to detect underreporting. So we are going to do it. And especially this critic study. It's a multi-country study through ICMR and IRT. Should be thankful to them. India, Indonesia, Nepal, Bhutan, and Sri Lanka, we are going to do this study on comprehensive intervention strategy. So you are also aware of that. So under this, we are going to do SciTB as well. Then also a pilot study on artificial intelligence guided TB screening. We are going to do this year to see how it is. Next, please. Yes, so there are barriers. So with gene expert module breakdown, it's a big barrier for us. Only about 60% modules working and difficulty in replacement, reporting issues, and providing social protection, and funding needs and gaps. Especially, as I said earlier, Sri Lanka is a low burden country, but we are stagnant, and most of the funding going to high burden countries, and it's like we are isolated. So there is a run, but we are just waiting outside. So please take us also along with y'all, so otherwise we'll miss it. Next, please. Yes. Yes. So funding, only a little amount we are getting because our government for TB is not a priority for them. We have to spend almost all that money on logistics, certain logistics, and that also not enough. So we are facing a lot of barriers. And as I see it from the program side of it, with this amount of only this limited amount of funding and technical support exposure, it's going to be very difficult for a country like us to move forward. Next, please. Next. 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 Yes, this TrueNet. We do have TrueNet machines, 18 machines, which were brought to the country during COVID time. So what we plan to do is now get them used for TB testing. So that's why we are much interested in this. So that's why actually we are, this workshop has been very informative for us, the visit and everything. So it will help us a lot. So this is one of our major plans for the future, because if we can't diagnose TB patients, we can't move forward. So I hope we'll be able to do that this in the near future. And thank you. I want, as a final word, I want to thank all of you for sharing your experiences here, which were very helpful to us, and also Molbio for inviting us. It was a great opportunity for us. And thank you all. Have a nice day.
Thank you. Thank you, everybody. It's been a very exhaustive 2.5 days. Well, 3 days now. We've come to the part where all of what we discussed from day 1, day 2, and this morning, Bobby has been kind enough to complete a draft statement on the accelerated plan that we would like to share. Just a few points that we took, which are more general from the various countries. What we did was, Bobby will show it for you, and he can take us through the declaration as well. We've called it the Goa Declaration. And as I had mentioned, if you can leave your email IDs, we can send it around and do a final cut with your inputs before we submit it. So, Bobby, can we show? Just for you, what Bobby's done is that we've taken all your presentations, what you presented, what the discussions were all about, and we took points which are common all across and have cited examples from various countries to back up anything that we had, added to the accelerated action point. So that's what we are just going to quickly show you. Of course, for now it's brief. We will send it to you, and then we can go back and forth. Hence, that QR code, which I had mentioned yesterday, is very important. Or if you filled in the sheet and it's clear, that's good, because we're going to make an email which is common for everybody, so that we can go back and forth on what we discussed. Bobby, should I read that part or? So this is the Goa Declaration that we have, based on all your discussions. You want to read it? Should I quickly read only the bits which are important? So that we can all. So what we've written is to meet SDG target of TB, we must find all TB, treat and prevent all TB in people-centered and rights-based ways. Now, all of this you will give your inputs into, so that we can then change if you feel there is a need to. We, all of us sitting here, and who's been with us throughout the 3 days, the delegates of the United Against TB Accelerated Action towards achieving SDG on tuberculosis, met in Goa, India, 15th to 17th May, recognizing that ending TB as a public health threat by 2030 is a public health and human rights imperative, as well as critical to advance progress on other UN Sustainable Development Goals and targets. We recognize that our world leaders have committed to TB-related SDG targets, which include achieving at least 80% reduction in TB incidence by 2030, achieving 90% reduction in TB deaths by 2030, and achieving zero catastrophic costs for TB-affected families. Yeah. Yes, then?
Yeah. So, so in this part, we have listed the SDG targets related to tuberculosis, which is reduction in incidence, mortality, and zero catastrophic cost. But we also need to, remember that our world leaders last September, our prime ministers and presidents of our countries, as someone in the audience yesterday had said, only one world leader was there at UNHLM on TB. Last year, this is true. Zimbabwe president was there, honorable president of Zimbabwe. However, because the political declaration was adopted at UN General Assembly. So all our governments are obligated to the targets of UNHLM on TB for 2027. So we really wish more political leaders and more world leaders participate. But I just wanted to re-emphasize that the political declaration of UNHLM on TB is as relevant to Zimbabwe as well as it is to any other country in the world. So UNHLM on TB 2027 targets are listed here. Bianca, should we read it or is there?
No, I think.
Yeah, all right.
We don't need to read it out, no?
Yeah,
We'll just read you the points.
Yeah, I think one of the things which is really important is the WHO called for 100% replacement of microscopy with molecular tests upfront was given in 2018. So that countries can do that by 2027. Our world leaders recommitted on this 100% molecular testing upfront again in September 2023 to be achieved by 2027. Some states have already done that. For example, the state we are sitting here in, Goa, it has already achieved 100% molecular testing. But so let's hope that all of us are, all countries everywhere, upfront molecular testing really becomes a reality. And we should not forget, we can't afford to have the people unreached. We have to reach everyone who is presumptive for TB, screen them, offer them molecular test, and link them to services and ensure there is no drop in the cascade.
How do we go up?
Yeah, okay. Oh. All right.
So again, here, this is basically what we've written, that we, the delegates, representing, all organizations, TB survivors, affected people, national TB programs, and so on and so forth. It just states that, that we are here and we would like to end TB in the next 70. If we are to end TB in the next 79 months, then it warrants an accelerated response to find all TB, treat all of them, and prevent any spread of infection with people-centered and rights-based approaches. So we put on record a few examples and successes that are helping countries move towards TB elimination target. Now, this list, as you can see, it's not in any order, it's not restrictive or exhausted, but it's just some of the impact success stories from your countries that you've shared, right, Bobby? Yeah. And we've just, put them all down. We may have missed some points, so please do add. Yes. You want to just... Should we read it? I don't know if you feel that we need to read it because it's a very long, I would, maybe we share it with you on an email and then you can at leisure do a little bit of a read.
So I just wanted to say what Bianca has just said, that all the countries which presented in this meeting, including all the presentations for introducing new tools project of Stop TB Partnership and USAID in Asia and Africa, and other presentations, and TB dialogues which have been conducted in the lead up to this meeting online. So that input has been taken into account in framing these. So for instance, this is what we heard on the first day, on day 1, from Dr. Ashwini Khanna and Dr. Chopra, Dr. Bornali Datta, Dr. Kuldeep Singh Sachdeva sir, more focused on India. Dr. Manish Gonekar ji, who's the Goa State TB Officer of About Goa. And of course, like you will also see, the political commitment came up consistently in so many other presentations. Yeah, and here you will find a background on the INTP and what impact those INTP projects had in Philippines, in Uganda, in Bangladesh, in Nigeria, in Ethiopia, in Tanzania, in Zambia, in Zimbabwe. And so as Bianca said, we will share it over email. Please be welcome to correct us. We might have made some mistakes, so please read it carefully. Be welcome to add to those points, correct us. We really want to capture it, really what you presented accurately.
Mm-hmm.
Yeah.
It's okay.
So this is the operative part, yeah.
Yeah, so based on those discussions and from all the inputs, we quickly took, we all together, the delegates, urge our governments and stakeholders to accelerate action towards achieving the SDG as well as targets enshrined in the UNHLM on TB, which is going to be in 2027, by wider scale up of pilots of introducing new tools project of the Stop TB Partnership and USAID, because they have shown impact in terms of finding more TB and linking them to care. Take the next one.
Yes. Prioritizing taking WHO recommended point of care TB screening and diagnostic tools to the people's doorstep over optimizing existing centralized or semi-centralized or lab-dependent tools or models which may have access barriers, result in diagnostic delays, catastrophic costs, and drop out of the care cascade. We really can't afford to do all this unless if we really have to end TB. So we really need to prioritize the latest interventions and taking WHO recommended point of care TB tools to the people's doorstep. Taking TB screening and diagnostics to the people or as closer to the communities, especially those who are more at risk of TB, is important. It will help reduce, there's some repetitions here, but it is to emphasize on the stop the further spread of infection, reduce human suffering, which is so preventable, and equitable access to latest TB screening and diagnostic tools can happen only when we make the best of TB tools available to the most marginalized or most likely to be left behind. Yeah.
And of course, effectively engaging communities in the response to TB at every level. Community health workers are the ones who are going to bridge a deadly divide between existing services and most at-risk population. More involvement of community-led monitoring, which is another evidence-based back method to engage communities, as well as to improve service uptake from the people's point of view. We must listen to the people and the communities we serve. Who said today that it's for the people, by the people. But so we engaging TB survivors with dignity at all level of the TB response, which will be a game changer. Upfront use of, where is it coming again? Sorry. The upfront use of microscopy must be phased out completely, replacing with WHO recommended molecular diagnostics. Tests, will you take that one?
Yeah.
Yeah.
So this is really important because we need to stop missing TB cases, even among those who take a TB test and get missed because of microscopy, which underperforms. Testing children for TB with samples that do not require them to expectorate a sputum. For instance, the stools have shown evidence of in children where TruNat has, there is evidence now to show that TruNat can detect TB in children using stool as a sample. If I understood correctly, is it right? Yeah. Okay. So, and other such interventions, it's really important. As one of the panelists today had highlighted, 70% of children with TB do not get a diagnosis. 70%. This is so unacceptable. They get TB from adults. So effectively integrating TB care finding and linkage to care services with other health and development programs, such as those on HIV, NCDs, HCV, the hepatitis, harm reduction, nutrition, tobacco control, among others. Many country presentations had these integration component. Lot of best practice examples are already happening in your own contexts, and we really hope that this gets scaled up. All right. With alarming number of TB prevalence surveys, which show a large number of people are asymptomatic. So it is really important to find all people with TB early enough. And we cannot do that unless we take TB screening tools to the doorstep of people. And now we do have WHO recommended ultra portable X-rays for population-wide screening. The Vietnam study and so many other INTP projects are showing you can find way more TB many-fold when we look for them with ultra portable X-rays. We find TB even among those who are asymptomatic. And we need to confirm those obviously with the molecular test. That is the WHO standard and call. And because it is so important to stop the spread of infection. Another very, very important point which came through so many presentations, so thank you so much delegates, was on same day test and treat. Even among those who are most marginalized, like homeless people, there are such great examples which were presented where same-day test and treat had become a reality. Despite challenges, it had become a reality. And it is really important because when molecular tests are available along with treatment and support near the key and other vulnerable populations, this is really possible to do this. Sure.
Yes, the next one is to ensure that universal drug susceptibility testing is a reality for every person diagnosed with TB. You heard the arguments today. There were a lot of, not only today, yesterday as well. So all this must be found and treated with medicines that work. And by doing a universal DST will also increase the diagnosis of the drug-resistant forms of TB, prevent the spread, and reduce human suffering and untimely death. Those cured of TB or who have completed the treatment should also be followed up with regular screening as per guidelines.
Yes, this is important. As Dr. Sachdeva sir had mentioned, it is important to follow patients as per the protocol. Sir, I think it's up to 2 years or as per the guidelines, 2 years, yes, even after the completion of treatment to ensure they remain TB free. So, yeah. So increased usage of mobile outreach clinics for population-based screening. Those testing negative for TB in TB screening, and among those where active TB disease is bacteriologically ruled out, TB preventive therapy must be made available along with full support, including counseling to complete the therapy. People more at risk, such as people living with HIV, contacts of TB patients, children, among others, be prioritized for TPT. Infection control practices in healthcare settings, communities, and homes be made possible.
Supporting governments to roll out all the latest treatment regimes, such as 1 month therapy for TPT, 4 months for drug susceptibility testing, and 6 months for drug-resistant TB. Also looking at the next point is people-centric, rights-based, gender transformative pathways, which are a bedrock of rollout for TB-related screenings and diagnostic tools, treatment, social and health support, and preventive services.
TB stigma, intersectional stigma, especially among those who have TB and a range of other issues such as HIV, gender diverse communities, or work-related stigma such as sex workers, prison inmates, among others. And self-stigma, it came up, as the hero said, it is one of the major kind of challenge which is faced by communities in Zimbabwe. And I'm sure it is here. All of us have experienced the warm blush or hot blush of shame. So self-stigma, internalized stigma, and all forms of discrimination must end. Unless we end stigma and all forms of discrimination related to TB, existing services will remain inaccessible for most at-risk key and vulnerable populations. The national TB programs and other TB stakeholders should tap into extra budgetary resources to fill the funding gap so that the response to find all TB, treat all of them, and prevent transmission is fully funded, along with TB R&D for new, safe, and effective tools.
So TB treatment is prevention, as people with TB of lungs who are effective treatment soon becomes non-infectious. Along with finding all TB and treating them with effective medicines, supporting them through the care cascade is equally important to make entire range of prevention method, TB prevention method make sure to have them accessible to people, such as tobacco cessation, quitting alcohol or other addictions, preventing and controlling NCDs, nutrition, infection control, TPT, among others. Did we forget diabetes?
Yeah. Diabetes. Yeah, we'll add it. Yeah.
No, it's there.
NCDs, yes. And so don't worry, there are only 2 left. And please add more. So the second last is reducing delays in translating scientific achievements into public health goals. We wrote this because, for instance, just Sri Lanka, delegates from Sri Lanka just said, why they have to wait for point of care molecular diagnostics. It was discovered years back. We need to reduce the gap between when scientific breakthroughs come out and they get implemented on the ground, and same holds true for treatment. So this is the important point. It will also create, and if we do this, if we can deliver the latest of technologies to the most marginalized, then we will create a pathway for rollout of upcoming health technologies if found safe and effective. For example, a new TB vaccine, which may become a reality if found safe and effective. But do we have the evidence that we can roll out the best of technologies to the last person in the queue or in the community without any delay, with equity, with dignity? If we look around how we rolled out COVID vaccine, we will get our answer that we really need to do better. The last one is engaging journalists and other media actors in TB response is important. Communication between media, TB scientists, researchers, survivors, advocates, program managers at all levels, other stakeholders is important to keep them informed, involved, and support them in increasing accountability and transparency in TB responses on the ground. Simplifying TB science and TB response in a language and manner which connects with masses is important.
We may have missed out points, lots of, because there was a lot that we discussed. Everybody shared what, what each country felt was important. Please do put in your inputs. We will make a timeline maybe for, going back and forth so that we don't sit too much on this, and we would like to share it as soon as possible. I don't know if making a WhatsApp.
Yeah, sure.
Both. This one I'll have to take your permission, because there's a lot of people who do not like to be in those long WhatsApp groups where there is just so many. So we will give you the choice to also be part of a WhatsApp group where we discuss a lot, better. So in the email we will send you, and then you can tell us whether you want to be added to the group, mainly just to get this, finalized so that we can then share it. Any thoughts, comments you feel that we should, this will anyways be shared with you, all of you. It's a lot to read through. Anything else that we add to this declaration? This is, it's all of us, our declaration. So we feel everybody should be part of it and take ownership and very much be interactive. So for currently, do you feel this is okay for now? And then we continue over email?
If you scroll down.
Yep.
Vice by vice, and then just start there.
Bobby, how do you?
Yeah.
Sorry? Yes, I will be sending it. Yes.
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 Yes. So we will send it to you over email. Right now, if you have any thoughts, if any point is missed out, see, basically there are two things. One is that we really want to document what has worked in your communities and countries. So what are the good things which have happened in terms of reducing the incidence, in terms of finding more people with TB, making sure that they get on the treatment, what lessons learned in rolling out new treatments and technologies. So that should really get documented, things which can be scaled up in your country, communities, and maybe inspire action in other countries. The last part of set of recommendations are more generic, but please be welcome to make it as comprehensive as possible. We do not want this to be just another declaration. We really want this to reflect the solid progress which you people have made despite so many challenges in each of the high burden countries and other nations which are represented here. Despite that, a lot of work has happened. So please make sure that that gets captured. And apart from that, points of action.
There are some countries who, in fact, from the Latin America group, we haven't received any. Have we received? We haven't received any information. So when you go back and you would like to include it into these, please send us your points. Okay, Dr. Tatiana and the others. Others also who, like Kyrgyzstan, we need to add a few things from your country as well. I think we've missed out on who else who could not present. Of course, Malawi, DRC, Eritrea, yes, Abraham, many other countries who we have not heard from. We can still include your points so that we can then put it as, example from Eritrea, this is what we learned. DRC, Anybody from the other countries as well who would like to add, please send your points. It is okay. You can send it even in French, no problem. No. We'll send you. C'est bon? Ouais. Thank you. Also from the French-speaking team, please send me your points. It could be in French, no problem. We will Google translate it. Yes. Yeah, sometimes, of course, the translations can be, but we will try our best to include it. Maybe have a French version as well later. What we can do also is once we have completed, we will request a French version and a Spanish version because these are the UN languages that, and Arabic as well. No? We will see how we can do this so that we can share because in the UN, we can send all of this together, especially in French, Spanish, and Arabic and English. We did. Should we mention the countries on there for everybody? Oh, yes, we mentioned.
Yes,
We've
yes.
said you're citing examples from.
Yes. So here it has mentioned that these are the best practices from India, from other countries. So for yeah. So
I think you meant in the
Philippines,
statement.
Uganda, yeah.
Delegates at the Goa meet.
Oh.
Now Goa meet is looks
Oh, all
very
right,
local.
okay, yeah.
We the delegates.
From 30 countries or something.
Ah,
Right,
okay. No, that's a good idea.
Good one.
What Shubha ma'am has suggested is we, the delegates from all the countries mentioned, all of you present here, your countries that we can add.
Yeah, yeah, we can correct.
Yeah. Okay, we will take from this will make more, it'll be a little stronger. Yeah, then it was,
Sure.
then we'll have
Yes, yes,
Yes.
yes. We will
we have
definitely
to
edit
make it more
yeah.
global. Yeah. Any other suggestion quickly for now?
And wherever your country is mentioned, I mean, in terms of the strength, for example, Philippines, Dr. Samantha's presentation or Dr. Laline's. So we will connect that to the PPTs, relevant PPTs where possible, or the recording links. Yeah. For reference.
Yeah. So based on this, do we have your permission to go ahead with this? Because we are all here united against TB, aren't we? Yes. So I just want everybody to raise their hands, the one who felt, okay, I would like to be a part of this. Woohoo! And feet. Well, thank you so much. I mean, this is great. We will share this with you and let's work on a strong document with all the countries' names mentioned and let's hope they listen to a very united, strong voice. We are 30 plus, right? Yes. And also don't forget to sign and endorse the global call. We have over 600 now.
Yes.
We have over 600 names online. There is a QR code there that you can also sign in as an individual and as a organization. Yes. 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 Yes, we just spoke to all of them.
Yes, ma'am. Please help us, finalize this. Yeah, thank you.
Right? Are we good? Yes.
Thank you.
I think we're doing good on time too. Thank you. Well, I just want to say thank you to TB People India, TB People Zimbabwe, and of course Citizen News Service with Shobha ma'am and Bobby for organizing this entire sessions. But I mean, without them, this wouldn't have happened. I just wanted to make a few announcements before I call on Mr. Sriram to give his closing remarks. Do we have any announcements to make? For the one, we need any announcements? Dinner? No, the dinner for tonight? Yeah. Okay, you have to, the ones who you can eat I think that comes to an end. And the ones who have not received their certificates, please come and meet us at the back. We've to cut short on time. We apologize, but we had to hand out, with permission from Shubha ma'am, we handed out the certificates at your seats. Those are mainly participation certificates. If you have not received your certificate, please, can you come to the back when you're taking your tea so that we can give you one? Yeah. So with that, I would like to call on the CEO and founder of Molbio, Mr. Sriram Natarajan, to please give us a few closing remarks.
Good evening. Like they say, all good things have to come to an end. We've had 3 days of wonderful deliberations, fantastic representation from 30 plus countries, speaking on their experiences, speaking on strategies that they're adopting and how they're progressing towards eliminating TB in their own countries, identifying areas of concern, areas of gaps that need to be completed and fulfilled. And I thought the bigger takeaway was the kind of sharing that happened between the countries, right? So everybody shared their experiences and each country could learn from the other in some way or the other. So going forward, I think this has set a wonderful platform, and I really hope that we can continue the momentum and keep engaging as we go along. Clearly, the objective is to see that we are able to really end TB. And everybody, if all of us contribute our might and take things forward based on what we discussed now and what we will be doing in future, don't see why this cannot happen in a short term. Time frames very difficult to define, but as long as we keep attempting, it will finally happen. So that's the belief. So I really hope that this has set some kind of a starting momentum for future, and we continue to engage. So I really thank all of you for coming all the way from your countries and spending 3 days here. Your coming here has been extremely important and extremely useful, and really appreciate that very much. I also thank the speakers and the panelists who also contributed their experiences and their knowledge for this event, and really appreciate all their efforts. I thank the organizers of the meeting, the people of Zimbabwe, people of India, TB people of Zimbabwe, TB people of India, and CNS, the Central News Service. And special thanks to Shobhaji and Bobby. Fantastic job done, fantastic organization. I mean, I've been attending a lot of conferences, but never seen something like this one, which has not been a very structured and straight-jacketed conference, but still achieved the objectives. Maybe much, much better than what the other ones did. So really, thank you very much for that. Yeah. Also would like to thank the members of the media who came again from their countries, of course, India and other countries, and spent time with us. I really wish the media will play a much, much stronger role. I mean, they've always been playing a good role, but taking TB on priority and taking TB something like on the same kind of a COVID mode, and ensuring that a lot of awareness creation and a lot of public health intervention happens through the media also is something I think is very important. Probably you can even think about, reporting TB on a weekly basis so that you can keep updating and keep that interest alive. And of course, countries will contribute to it and all the stakeholders will contribute to it. Maybe you can also have a research wing in your own organization who can also dig, stories. But keeping this momentum going and keeping a regular TB update on the media probably could also play a very significant role. So thank you very much for coming, and I hope along with you, we can go a long way in the TB elimination drive. I also wish to thank my staff Molbio team who helped in the logistics and ensuring that you are all comfortable and everything is, I hope it was comfortable. We have tried our best to make sure that that happens and that all your needs have been taken care of. If there have been any drawbacks, I apologize for that, and we will try to keep improving, but I can only say that everybody did it with all their heart. Yeah, so I thank the team for that. And I thank the hotel and the staff of the hotel for hosting us in the hotel and making sure that everything happened the right way. Excepting for the AC, probably which suddenly cooled too much or heated too much, but everything else was fine. Hopefully they'll get it right the next time. So once again, thanks for that. So I think we have come to the end. So thanks to everybody again, and hope to be in touch and hope to meet you all soon again. Thank you. Bye-bye.
So sorry. I should have written this down. There is another QR code there. That is the feedback on the 3 days. Did you like this? Did you like that? How was the dinner? How was so it's more on logistics and more on organizing. Please do give your feedback. Anything is good for us because we improve. And of course, you can also add in your comments and anything that you feel on that form. That's all would be highly appreciated as well. Just one more thing, for those of you who are interested in seeing the ultra portable X-ray for screening for TB, we have it out there in the back. So we have some of my colleagues who can show you about the X-ray and how it works. So thank you so much and have a safe flight back.